That makes sense. And have time. That's an excellent point. So that in a team environment, you have the ability to have a division of labor so some of these things can be addressed. And even if you can't address these things, it's good to at least know that the phenomenon that we're asking people to embrace, adherence, is not something that just happens because we say do it. It's a little more complex than that. There's some attributes that stand as barriers to feel happen in a very perfect kind of way. Those are the possibilities. Good. Mm-hmm. Mm-hmm. Right. Absolutely. Right. And of course, we have a role. In each of these four areas as a clinician. The different expectations for communication. I didn't vote in the training model to have a different. So there's sort of an implicit role. But I think what you're speaking of is something that's more explicit in terms of the role that can actually appear in the model to have some explanatory power in terms of what the role needs to be or is. Good point, Dr. Buddha Foster.
Thank you, Dr. Lewis, for your talk. I think that's a very important point. And as physicians and nurses, allied health professionals, PT, occupational physical therapists, we have to be aware of our own unconscious biases that we bring to the relationship. We make a lot of assumptions about what patients cannot do. And in doing so, we contribute unknowingly to health disparities by not providing that patient with ART because we don't think they're going to be adherent, or this medication is too expensive, so I'm not going to give it to you. I think the other thing is there's a big literature on physician inertia, aware of the guidelines, in particular, let's say for something like diabetes, that we don't, diabetes or hypertension, we don't adhere to the guidelines closely enough. So therefore, while it may appear that the patient is not adherent, that may be the case, but because we're not aggressive in adhering to the guidelines and getting patients to target. I think Dr. David Stevens was supposed to be here, but he pioneered a model known as treat to target for hypertension. So that's a great point.
Yeah, and speaking of the bias, of course, as human beings, we all have biases, and one of the things that you should do as a provider is always be in touch with your own biases through a constant process of introspection and being self-aware and identifying each bias and understanding whether or not it's a bias that's open to change. If so, do whatever it takes to change it. If it's not, and so it doesn't rear its head in a negative way in a clinical setting, and constantly be doing that all the time. Go ahead, ma'am.
Adding to what was said already in terms of the clinicians and the biases, many times we look at the word adherence and it may not necessarily be, it could be cultural. And we don't really take that into consideration.
Could be cultural, you said?
Cultural.
Yeah, usually it is. And when we say culture, when I say culture in this setting, I don't mean culture with a big C, meaning race, ethnicity, and those categories that we all think about. I mean culture with a little c, because each one of us has our own unique individual culture. So it's not necessarily those traditional cultural variants, but the fact that any two people, even two identical twins, who are the two people who are the most alike of anybody in the world, have different worldviews and different cultural realities. So, yeah, absolutely. Oh, actually, I forgot I had a few more pieces. How do I advance this? I'm trying a new thing in my presentations, add a little humor, which I typically don't do. But yeah, so here we go. Here's an example of the worldview difference. Both individuals are looking at the exact same phenomenon, but because their vantage points or their worldviews are different, they see something different. Oops. Andy Capp. Remember Andy Capp? That sounds like what I would do. So the best thing you can do is give up smoking, drinking, and fried food. So what's the second best? I'm not going to do all that. So what's second best? And so the danger is that it's great if there's a dialogue, explicit, that occurs. But what happens is that the physician says the best thing, and the person like Andy Capp doesn't necessarily, he's thinking it, but doesn't articulate it. And so therein is the problem. If he articulated it, then you could actually have the dialogue could continue, and maybe there's a way to make the adherence more likely. But usually what happens is, what's the second best is just an internal dialogue that's going on that, you know, that you think, okay, well, all right, I'm going to modify that to make it fit what I want to do. And certainly we become frustrated, but we don't want to do this. I've been here so long, don't remember what I did, but it had something to do with non-compliance. So we don't want to get to that point, but we feel that way sometimes. That's what we want to do for folks. Okay, that's it. Thank you.
So thank you, Dr. Lewis. And I'd like to invite Dr. Michael Joseph to the stage. Dr. Joseph, with my glasses, is an assistant professor in the Department of Epidemiology and Biostatistics in the School of Public Health. He is also the director of our training component at Brooklyn Health Disparities Center.
Good morning, everyone. Before I introduce our next panelist, I'd like to share with you, last night I was watching for the first time the Golden State Warriors playing against the Oklahoma City Thunder. And everyone is fascinated with the Golden State Warriors because Kevin Durant left OKC to join forces with the Golden State Warriors and form what everyone is calling this super team. A super team of basketball players that, you know, Golden State Warriors, and everyone thinks that, you know, Golden State is gonna just surpass what they did last year. But I'm here to tell you guys that we have a super team of panelists here today, here at the Brooklyn Health Disparities Center. So our next speaker, and you already heard one, Dr. Lewis. Our next speaker, who's gonna talk about application of psychosocial theories to understanding adherence, is Dr. Carla Booten-Foster. She's the Associate Dean of the Office of Diversity, Education, and Research. Please join me in welcoming Dr. Carla Booten-Foster.
So thank you, everyone, for inviting me to this interdisciplinary dialogue on adherence. So I have no conflicts of interest to disclose. So the learning objectives. So at the end of my 15 minutes or so, the audience should be able to describe the consequences of non-adherence using hypertension as an example, and to also understand and apply some of the social science theories as a framework for describing the psychosocial context and cognitive determinants of medication non-adherence. So what is adherence? Dr. Lewis already alluded to this, that adherence is the extent to which patients take medications as prescribed by the healthcare providers. And as Dr. Lewis previously said, we've moved away from the term compliance, which suggests that the patient is passively following the doctor's orders and that the treatment plan is not based on therapeutic alliance or contract established between both physician and the patient. And when you think about adherence and compliance, you know, on face value, they really don't sound that different. And what Dr. is advocating for is if we move towards a concept and a construct of patient engagement and activation. So why are we discussing adherence? What is the significance and what is the premise for this talk? Well, non-adherence accounts for about 125,000 deaths annually. We know that 20 to 30% of medication prescriptions are never even dispensed. In fact, patients don't take it to the pharmacy, right? So check the garbage cans in the doctor's office. You'll see, you know, a Metro card and medications that their intention is never to. Approximately 50% of medications for chronic conditions, in particular cardiovascular conditions, are not taken as prescribed, and 30 to 60% of the medication-related hospital admissions are due to non-adherence. So if you think of patients coming in for CHF, patients coming in for hyperglycemia, or with cardiac arrhythmias from end-stage renal disease, it's likely attributable to non-adherence. And the resulting cost is about $100 billion. Can you even count $100 billion? And yet we're contributing You know, both providers in our role and also in not helping patients to the best of our ability, contributing to this $100 billion cost. So the significance of non-adherence is particularly relevant for racial and ethnic minorities in the context of hypertension. Okay, that's right. Yes. So African American adults have a higher prevalence of hypertension. We know that compared to other racial and ethnic groups, as well as compared to whites. African Americans, as a result, experience higher rates of comorbid conditions such as fatal stroke and 4 times the rate of end-stage renal disease. And a major contributing yet modifiable risk factor is non-adherence. And the thing about health disparities is, yes, there are a lot of immutable for health disparities if you're talking about epigenetics, but a lot of the health disparities are due to things that we as a community can address on our own. So a lot of the factors that contribute to health disparities in cardiovascular disease, in particular hypertension, are modifiable. So everyone has experiences with non-adherence. So I want you to raise your hand, and I'm going to be HIPAA compliant, so you don't have to disclose what you're on or what you're taking it for. But if you or someone you know is taking a medication or has taken a regularly prescribed medication, ever, raise your hands, up, don't be shy, don't be shy. Okay, keep your hands, keep your hands up. Now, keep your hands up. Your hand should stay up only if you've never missed a dose and if you always take the medications as prescribed. So fewer hands are up. And the thing about it is providers may not know this, right? So we think it's important for physicians coming up, early physicians, to understand the challenges that patients may have with adherence. So what we did just a few weeks ago with the first year PBL class, right? Yeah. The first year PBL class, we introduced students to the concept of adherence. So we told them for 6 days, beginning on Tuesday, ending on Sunday, take the pink pills twice daily. Take the orange pills once daily, and the yellow pills 3 times daily with meals. And this is basically, they had candy. No, we're not prescribing students medications, okay? Just to let you guys know, we're not doing that. But we gave them little candies, right? Sweet tarts, I think they're called. I think we have about 180, 190 students in the classroom, in the school, the College of Medicine. All students acknowledge, yes, we got the assignment, you gave it to us, and yes, we got the prescription, right? Only 5% of the students completed it for the total duration. In fact, most students said they gave up after the first or second day. They just gave, and this is candy, people. Right? We couldn't get them to take candy, right? And these are some of the comments that they said. The first challenge was motivating myself to adhere to the regimen. I sometimes would forget to bring my medications with me to school, which caused me to miss a dose. I noticed that when my pills were out of sight, I generally forgot them. Overall, this experience was very insightful in that it reinforced some of the challenges that patients encounter when trying to adhere to a treatment. Greater appreciation for the challenges they encounter, and will be able to offer some strategies to help them overcome these challenges. Now, the students did realize that what they experienced really paled in comparison to what patients taking medications experience. And in fact, some of them said, I didn't think it was important. But the interesting thing is that a lot of our patients that we give medications to, they don't know why we're prescribing. You tell a patient, you're taking your medication for diabetes. I don't have diabetes, I have a touch of sugar. So they're not taking their medications for diabetes. And when you think about what the students said, and also if you think back to the schema that Dr. Lewis had, it really brings home a lot of some overarching themes of non-adherence: the lack of motivation, lack of time, perceived beliefs about efficacy, and enabling and reinforcing factors. What I'm going to turn to now is to talk about psychosocial theories that are commonly described in the literature, and that can provide a context for talking to patients about adherence and for developing research interventions in educational curricula. So several social science theories on medication adherence exist. There isn't one theory that will fully capture all of the nuances of adherence or non-adherence, and many of them are overlapping. Right? So the social ecological model really sets the stage for how we should approach adherence. It's not only an individual level challenge. It involves the provider, as was mentioned before. So it's individual, interpersonal, the doctor-patient interaction, organizational, the way of how far do you have to go to the pharmacy to get your medication? Is there an inpatient pharmacy? Is there an ambulatory care pharmacy? The community, what does the community think about adherence to a certain medication? If we think about medications for mental illness and how it's stigmatized, community and public policy. You know, why are people paying $300 to $600 for EpiPens, right? So what are the policies that really support and contribute to non-adherence? So medication adherence does not occur in a vacuum, and it's determined by perceived discrimination. There have been studies that have demonstrated that those who perceive higher discrimination in the provider-patient encounter are less likely to report adherence because I just don't trust you. As simple as that. As simple as that. And we don't think of, when we think about discrimination and bias, we don't appreciate the impact that it can have on patient outcomes. So there's access and policy and social support from family. So interventions must really promote medication adherence, must do so. Adherence does not occur in a vacuum, and there are multiple factors that must be considered. Social cognitive theory is a commonly used theory. Its predecessor may have been social learning theory by Albert Bandura. Social cognitive theory addresses the social and cultural context and personal determinants of adherence. So some of the key constructs of social cognitive theory include observational learning. Basically, we're observers. We see and we do. Right? Reinforcements. What's the reinforcement for taking this? Self-control. There has to be a modicum of control and self-efficacy in that you have the confidence to do it. And reciprocal determinism just says that the behavior will impact the environment, and in turn, the environment impacts the behavior. In other words, someone who's really serious about not smoking, not drinking excessively, they will not associate with the same crowd. They will be active and proactive about creating an environment that's conducive and that sustains a new healthy behavior that they've adopted. However, in the wrong context, the environment can inadvertently contribute to non-adherence. You're losing weight. Why are you losing weight? You think you're better than me, or you think you're sexy now? I can't believe you're losing so much weight. You look sick. You know what people are saying about you, right? So then what happens? You know, or you're too skinny. You know, I like women with a big junk in the trunk, right? And these are loving terms that people use, and yet it may deter people from being adherent to not only medication. I know we're talking about medication, but there's also adherence to physical activity, smoking cessation, and so forth and so on. Health belief model says the way in which we appraise certain situations may determine how we adhere or not. So how serious is this? If I don't take my blood pressure medication, how serious is this? How susceptible am I to a stroke? What is the threat of a stroke? What will it do to me? What will it do to my family? What's the benefits of taking this medication? I heard that there are a lot of risk factors, and you really can't trust what the providers are saying. So is there really a benefit? It takes me a lot of time to go and get this medication. It costs a lot. So what are the barriers? Will this even work? I've been taking this for a year, and my blood pressure is still the same, and every time I go back to the doctor, the medication goes up. I'm on insulin now. The insulin is going higher and higher, but why is that, right? So your perceived benefits and effectiveness of the medication. And then there's self-efficacy. Can you do it? And personal modifying factors in terms of one's age, gender, race, ethnicity, culture. These are all factors that contribute to our understanding of adherence. So the stages of change model, trans-theoretical model, Prochaska and DiClemente, I believe, are well known for describing this theory. It says that health behavior does not occur linearly. So it's stages, but it's also cyclical, that you can go from maintenance back to why am I doing this in the first place, especially if you don't see immediate rewards. So the thing about the trans-theoretical model of change is that it's not linear. And it includes pre-contemplation, contemplation, preparation, action, and maintenance. So interventions have to be stage-based. You have to know where your patients are. If the patient does not believe that he or she has a problem, then to say, I'm going to put you on this medication for what? You're the problem, not me, right? So we have to know where patients are before we start giving them medications. Self-determination. I love this theory because it's simple. It says, in order for health behavior to change, the individual must own it. As Dr. Lewis said, he has to believe that he's the one who has to change, not everyone else, but I have to change, right? So you have to own the behavior. You have to feel confident that you can do the things that you need to do, and people have to be supportive. Ryan and Desi helped pioneer this concept, and it's about self-regulation and self-determination, and you're your own agent, but you have to own it. So we have to get individuals to own, be identified by it. You know, not to say I am a diabetic and that's all there is to me, but yet I'm going to control this. I'm going to exert as much control as possible, right? So these are some new, they're not necessarily theories, but they're concepts that are really interesting in terms of how we think about patients' challenges with adherence. So the SPRITE study was a multiple trial study that looked at systolic blood pressure control, and it was a multiple telephone-based, nursing-based. And what the SPRITE investigators did was they looked at a series of questions known as chaos, right? Life organized? Is my life stable? My routine is the same from week to week. My daily activities from week to week are unpredictable. Scheduling a meeting is difficult for me. I don't like to make appointments too far in advance because I don't know what might come up. That's what I say all the time. So there must be a lot of chaos in my life. So after adjusting for demographic, socioeconomic factors, what they found was that the higher the score of chaos, the poorer adherence. So with 1 point increase in the chaos was associated with 7% increase. The more chaotic one perceives their life to be, whether or not it is, the poorer the adherence. And we did a study. This was a study that we published, I think it was in Ethnicity and Disease, and it was a trial that we did to look at medication adherence and controlling blood pressure control in hypertensive. So overall, 80% of our participants were adherents. Unfortunately, there wasn't a difference in the way in between the control arm and the intervention arm. However, we did see increase in adherence. But yet, among those who were demoralized, the adherence rates were lower and the blood pressure control rate was lower. And also among those who were demoralized and depressed. So demoralization is a little bit deeper than depression. It's more hopelessness. What you do, it's not going to work. And the interesting thing is that people who are demoralized may not necessarily think that they're depressed. But demoralization leads to inaction, right? So these are some of the findings that we saw. Self-affirmation. Now, the thing about it is Dr. Lewis said, when we tell patients to change, and that's saying something to them that something just isn't right, and I want you to change. And as adults, we do not like to change, right? As a matter of fact, most of the discussion with my husband at the dinner table is he doesn't realize that I'm right and he must change, right? So people inherently do not like to change because when you tell someone to change, it may be viewed as an affront to who they are. And it's the whole concept of stereotype threat, that people may not perform as well because they're reminded of deficiencies. And we do this unconsciously, right? So just reminding people of who they are. And again, that you are not this disease and you are able to control this. And wow, you lost 20 pounds a couple of years ago. I know you can do it again. How did you do this? So focusing on prior successes as opposed to potential failures. And in fact, there was a recent study that was done among school children and found that if you encourage them and tell them what they can do as opposed to what other people like them cannot do, they're more likely to succeed. So I'm starting to think about when I talk to my patients about adherence, sometimes I say, do you know as African Americans, we are more likely to? And as I think about that, we're really setting them up for failure. We really can, and I have some amazing patients who have been able to overcome this. What are you proud of? What have you done? Excellent, you got your kids through college, all 6 of them, wonderful. Well, you know what are we gonna do to address this hypertension? So we really have to reframe how patients view illness and not do it in such a way that challenges their integrity. Culture, as someone mentioned, is very important. Who knows what, first of all, we're in Brooklyn. How many Haitians are here? Okay, raise your hand, be proud, thank you, step by say, okay. Haitians, oh, see now, okay, excellent. I'm Haitian also. So much of my medication knowledge comes from my mother, who when she comes over, she's always looking in my backyard for some root. Right? So I don't know, okay, here we go. What is this? Aloe, right? And this? Almond leaves. Almond, yes. My mom figured out a way of not taking her medication for diabetes by taking almond leaves until she went back and her A1C was higher than the normal level. And she's like, maybe I need to take my medications with my almond leaves, right? So she makes a tea out of it. And what about this? Right? So there are a lot of things that our patients are using that we have to be comfortable asking them. And it can be, and we often use this culture as a barrier, but it's not. It's a resource that can be embraced, right? In conclusion, hypertension contributes to excess mortality, especially among racial and ethnic minorities when it comes to cardiovascular disease and other chronic conditions. Medication adherence is paramount to reducing disparities. Interventions must be interdisciplinary. So I just love the fact that Dr. Straker, kudos to you for developing this interdisciplinary dialogue, because no one health profession can do it alone. Interventions must also apply multiple theoretical perspectives. They have to be patient-centered, promote self-efficacy, reinforce social support, align with one's health beliefs and culture, and enable patients to maintain a modicum of self-integrity. Thank you.
Before you leave, are there any questions, comments? Well, I have one. Morbi, right?
What is that?
Morbi is one of the things used to lower your blood pressure.
They don't
And
have
so,
that in
you
Haiti.
see, my grandmother, well, they have it in Barbados.
They have them in Barbados, okay.
So my grandmother was famous for giving
It's a
us
drink?
all, yes, well, it's a bark, and then you boil it, and then you drink it. So how many people know about that? Okay, all right. So, are there other questions? Just 1 minute.
So I'm thinking as a provider, and I'm at Harlem Hospital, so I deal with a lot of that cultural. And so do you think that also we can recommend our patient, because I know that cultural part, and I see them coming with all these bags of different things, showing me and saying, doctor, I take this, I take that. So at times I try to tell them, even though you're using, whatever mix up they get in every way, maybe you can also try to, because we don't know what is interacting with the medicine, but I try to explain to them like the physiological, how medication work as compared to these herbal or whatever you might mix up and bring in. It's not the same effect. And sometimes that really comes across to them like, oh yeah, doctor. Yeah, that's true, because I feel this way. So maybe because we know the culture is really built in. I mean, part of my family's from Jamaica, so my grandmother always gives all these, I don't even know what they are. She said they help this and that or whatever. But somehow I think that culture part play a lot, because I try to tell them, well, if you're gonna stroke out in the ED or something, that we can know what medication to work with. So I think that we really need to get that across, because that is so deep, especially in certain area where you're practicing, that really makes sense.
I totally agree with you that it is. And that's the whole concept of cultural competent care and teaching our providers cultural competency, that it's not always them against us, really, in that culture can be embraced and learning about what patients do. And a lot of patients on alternative medications, but they're not necessarily alternative, they're traditional. We call them alternative medications, but they're really traditional medications. So I totally agree.
Thank you, Carla, very much for the talk. One of the areas we're having problems with is immunization adherence. Could you make a comment on how we could get it up using those social and ecological theories?
I think immunization, health belief model is a nice construct to address immunizations. So it's really understanding what is the person's perceived, like if you do not get measles, mumps, and rubella, if the child doesn't get measles, mumps, and rubella, or what is the seriousness? What is the threat? That what do you understand will happen? And it's really getting the parents in this case, or maybe adults with the flu vaccine, to first understand, things like you will not get the flu from the flu vaccine, and what is the seriousness? How susceptible are you to getting influenza? Not only you, but as a healthcare professional working with other older adults. So I think understanding their knowledge of the vaccine, how susceptible they are to not getting the vaccine, the benefits and the barriers, and then working together to come with a solution. So I think understanding their health beliefs around that is really important.
You have to from the School of Public Health. So is there I know there is a need for immunizations. Everybody understands that. But I'm not sure that we're doing enough to educate the public on what it means to have all these immunization schedules completed. Do you know anything about any organization involved with this campaign, educational programs that would allow specific communities to actually be more knowledgeable? Because I know the immunization problem is a problem overall, but minorities are the ones that are actually more affected in this equation than anyone else. So the question is, what are we doing? Because the only thing I see on TV is negative. In other words, somebody is saying that it's not good. I don't see that people are saying, okay, you have to have regular checkups and you have to have your regular immunizations because this is the benefit. I don't see that at all.
No, that's a great point. I mean, local pharmacies are trying to do things with the flu vaccine, with demonstrating that it's okay. But I agree, we definitely should do more. Dr. Sweeney, in terms of the public health thoughts, what are your thoughts?
Yes, I want
That's a great question.
bring up two issues with immunizations. A lot has to do with having a relationship with the patient and having the patient trust you. So our commendation at Bedside Family Health Center that was presented by Tom Frieden, of all people, because over 90% of the seniors in our health center were immunized against flu and pneumonia. Now, they knew the doctors. We also had an active program. We also had a video. We also had a questionnaire to address it. We had people standing in the waiting room talking about the value of getting your immunizations. And then when the patient came in, they had an opportunity to express why if they didn't want to accept it. Final straw was, I would say, I know that you would never sue me if you ended up in the hospital with complications of flu or the pneumonia. But your family would say, my mama is up in that place every year. Why didn't she get her shot? So all I want you to do is just sign the paper that said, we offered it to you and you refused it. That got the last 5%. So Dr. Frieden took that form back and put it on the Department of Health's website. So you have to use multiple approaches and you have to take a lot of time and a lot of education, but it can be done in our community.
And another thing, Dr. Sweeney, it's not only because we know that there may be a lot of distrust between the provider and the patients, but it's not only a provider saying it, it's who else they're listening to. Who will people listen to? A lot of people will listen to their imam, rabbi, and priest. So engaging places where people go to frequently and hearing the message that it's not incongruous with your faith. So reaching out to people outside of the healthcare, and I think engaging faith-based leaders to discuss with their congregations vaccinations is something that has health benefits. So that's another route.
The questions, comments? I just want, what's it?
Hi, my name is Melinda Vargas. I'm a community health worker from Canva's Eye Care program. And when you were speaking, one of the things that popped in my head was a lot of the people who take metformin for diabetes, but they don't eat because they don't want their sugar to go up. So one of the things that we usually do is we usually go to their homes or we speak to them in the office or over the phone or text message. And we talk to them about the importance of eating while taking this medication, because this medication is not going to work unless you eat. If you don't eat, when you finally do eat, your body's going to store that, and that's what makes your blood sugar to go up. Another thing with the immunizations is we work very closely with Healthy Families Nursery in partnership in these other programs, and they actually do go to the home and speak to them about the importance of doing the immunizations, as well as the breaking down the barriers and their side effects. Because a lot of times what happens is there's a lot of information out there about immunizations causing autism and other things, and we debunk that information because a lot of times they don't know that this research was done way before and it didn't have any facts behind it. So we're there to basically become that bridge between the doctors as well as the patients.
It's important also in your healthcare setting to have a champion, because 2 years ago, the Department of Health said that all pregnant women are supposed to receive the Tdap. And we had one nurse who worked there at the time who convinced scores of patients to have that Tdap. That nurse left, and we have a lesser compliance rate at this point in time. So in addition to the providers, the physician providers, the nurse providers speaking to the patient, actually one person there has to really be the cheerleader. And we had a patient who came to us from pediatrics. She was seeing us in OB, she was pregnant. She refused to have the shot, but she went to the pediatrician, and the pediatrician was so upset, she started to cry, and she ran back over to us to get the shot. So it's the passion that the doctor showed her, that she was really worried about her, that made her come to get the shot. So you really do need to have a champion in your midst, in addition to everybody else educating the patient.
Someone just asked me if I was related to a teacher I had in elementary school. So, I just wanted to, oh, we have another comment.
Presentation, you mentioned the medications that, or the prescriptions that are not filled. And I think in that perspective, there's a lot that can be done. I don't know all the answers. May be able to do something as an advocate. Very briefly, I would like to explain something that happened to me on 2 occasions. I was on a board with a volunteer organization whereby medications were disparately dispensed. And also I frequent the pharmacy that when a patient would go in, they would not really want to accept their medication because they felt that the medication was not appropriate for them. And so in that case, they would walk out. So what I did is I kind of spoke to the client. I spoke up as a healthcare provider and tell them why was it important if they did not wish to take that medication prescription, that they should then communicate with their physician. And in addition to that, I also went further in terms of legislature and in terms of making certain that that particular pharmacy did not dispense disparately. And needless to say, that pharmacy then moved out of that particular community. So we need to make certain that we are speaking up for the clients and helping the clients to do things that they may not know that they have the right. And one thing that I can constantly tell the clients who get medication, when they sign that they have, when they tell them you're getting this medication and you must sign, they are signing that medication has been explained to me and I understand, but in reality, they have not told the client anything.
There's another, it's not a theory, but it's a planning model, predisposing, enabling, and reinforcing. So we do need reinforcements throughout the healthcare system. So going to the pharmacy is really important, especially when people may go to the same pharmacist over and over again. So to have the pharmacist play a key role in adherence. Absolutely.
Right, I'm going to take. Very high.
That's a great question, and it's multifactorial. It stems from, I mean, if we go from the perspective of the provider, it's lack of cultural competence and not providers not necessarily meeting patients where they are. It's unconscious bias, not escalating doses or providing patients with that will help them. It may be the provider may feel that the patient may not understand. If you look at the patient-related factors, there are a lot of social determinants of health. There's access to care. There's also interaction. You know, when you go to see the pharmacist, how you're treated, there's trust, perceived discrimination. Cost is a factor. However, studies that have been done at the VA where medications are paid for, and this is before Affordable Care Act, showed the same difference. So I think for racial ethnic minorities, there is the cultural factor, but there's also the interaction with the providers and the trust. There's also language, and it's not only that the patient does not speak our language. How many of you, we have so many Haitian patients in Brooklyn, and yet not many of us speak or Spanish fluently for that matter, or Urdu, right? So it's also the providers not speaking languages or not having access to competent translators as well. And then there's also belief systems in terms of what will this medication do for me, and priority and time and chaos. And I'm not saying that racial and ethnic minorities are chaotic. However, because of a lot of psychosocial factors that we're confronted with, medication adherence just becomes something extra. We provide medications as if I'm not doing anything all day except for taking medication, so bring it on. But there's also going to school, picking up your kids. Kids aren't hurt, you know, there's violence. There's all of these things that the racial ethnic minority communities are confronted with, that when you add medications to that, medication adherence may not be a priority, especially for conditions that are silent, like hypertension. You don't know you have diabetes until you have diabetes. So there are a whole host of psychosocial factors, and that's why the social ecological model allows us to look at it from the individual factor as well as policy, you know, all the way through policy. So there's a whole host of factors that disproportionately impact communities of color and immigrants as well. So that's a great question. Thank you.
Hi, my name is Nersha. I'm a new grad nurse here. Just to kind of ask, there's been several instances where, you know, as a nurse, you go up to a patient and you ask them, you know, have you been taking your medications and whatnot? And the patient will say either yes or no. And then at time of discharge or even upon admission, you go through medication adherence, you highlight medications that you need to take and when you need to take them and whatnot. And a lot of things that I've noticed was, even despite patient education and, you know, home care and whatnot, patients still come back because they're not adhering to medication regimen. And I'm just thinking, I've always thought, what more can we do? And I don't know, because we've done the whole patient education, we've done the nursing care, we've done the phone calls. What more can we do to have them own up to their health condition and taking medications?
I mean, that's a great question, and I think Dr. Sweeney alluded to that medication adherence does not only occur during the provider-nurse-patient encounter at the time of discharge, but it also occurs at home. So you may prescribe the medication in the hospital, but the decision whether or not they're going to continue to take it occurs at home. So perhaps speaking with a family member if the patient gives you permission. Identifying who else in the community do you speak with. Calling the pharmacy, calling the patient back. You know, what I often tell residents is that provider-patient encounter does not have to stop at the provider-patient encounter. Call the patients. How are you doing? How is it going with the medication that I prescribed? Have you been taking it regularly, every day as prescribed? You know, what are some of the challenges? Okay, so I'm going to check up on you again, and we can discuss. So I think it's prolonging the discharge planning after discharge also.
Hi, my name is Marie Vincent, and I work for HCC. I just wanted to thank you very much for your presentation. Really well spoken. I've learned a lot. What I wanted to chime in on was with the immunization. For instance, I went out and did outreach for a pop-up flu shot that we were having. and also to promote the fact that we do free HIV testing. While going out, I was under the impression that once I started talking about HIV testing, everyone would get scared. But then with the flu shot, everybody would show up. Once I mentioned the flu shot, I was like, no, I don't want to do that. I don't want to. But HIV testing, they were okay with it. And it was like, it was mind-boggling to me. I was like, really? And so I started asking questions. What's going on? Why wouldn't you want to take the flu shot? Oh, no, I don't want to take the flu shot because I already know they're just experimenting on us, on all that. So in regards to this gentleman's question, in regards to like, the minority groups and the Caribbean, what is going on? How come, people not adhering to that? It's because a lack of trust. A lot of patients believe that the doctors, like a contract with the pharmaceutical companies. So I don't need this medication. They're just making sure that they give it to me so they can make their money or whatever with the pharmacy. And when it comes to the shots, they're just experimenting on us. So this is what they believe. So it goes back to what you were saying in regards to trust. There has to be real trust, because even if they say, I'm going to take the medication, throw it away because they're like, you're not going to experiment on me. I'm going to stick to my ginger tea when I have the flu because that worked for my family, and I'm going to continue that tradition, and it's not going to cause me to have kidney failure or whatever else that they believe. So I think that, establishing a real sense of trust will make it easier for the patients to take their medication.
I think you're absolutely right. I think my mom thinks that I work for the pharmacy part-time because I'm always telling her to take this. But I think we really have to state that it's not all about the patients, and that there is for this trust. And I don't want any of the that as racial ethnic why should I trust doesn't look like me or who may be not have my best interest at heart. So there is a social political construct that underlies adherence as well.
So I would like to give a big hand to Dr. Booten Forster because that was just a great presentation, and I'd like to thank the audience. The interaction is wonderful. I would like to take now the opportunity to introduce to you Brooklyn Borough President Diana Reyna, and she has been in the community for many years. I'm sure she'll share some of that, but she comes to the stage now to speak a little bit about Brooklyn Health Disparity Center.
This was a great presentation. I have to say I was chuckling inside and as well as with the audience in certain parts where you would identify with what the doctor was mentioning. I come to you as the Deputy Brooklyn Borough President, but also as a patient in Brooklyn. And we must not ever forget how we need this type of connection to what can easily be forgotten or glossed over. That sense of reality, the day-to-day in New York City. It's a fast-paced urban environment, and that alone can create the chaos that Dr. Foster was mentioning, right? The issue of, have I taken medication if I'm running late for work and I'm late to take the kids and I'm late to make that first conference call in the morning, and I haven't looked at my calendar to understand where I'm going, and I still have to make sure that my parents took their medication and they're up and about, and my dad doesn't fall because he suffered a stroke. Just giving you a little sense of what I'm dealing with. The candle's burning on both sides of the stick. Once a man, twice a child. And that sense of, can we juggle it all? We have to pause and we have to really start thinking about what is the patient going through? and actually understanding of what it is to adhere to medical expectations, to continue a sense of lifestyle that won't demoralize. My name is Diana Reina, and I'm the Deputy Brooklyn Borough President. On behalf of Eric Adams, we just wanted to thank this institution, SUNY Downstate's Brooklyn Health Disparities Center, one of great value. And, you know, as I was listening to the presentation, I was just telling myself, how great would it be to just take this presentation into the classroom for every child to listen to, breaking down information and expecting an adult to understand it when it's just being presented to them for the first time because they're ill. Way to deal with health. And if you age down a presentation like this, I think it goes a longer way to creating a culture, a shift, a mindset shift, a culture shift around better healthcare and what that really means to the individual. And when you talk to a child and how that child brings it back to the home, and then we're catching the family at the top and at the bottom, there's no way they can escape. And so I wanted to just share that. And if there's an opportunity for us to work with the Disparity Center to take this presentation, you know, every child has to have some type of health course. A 30-minute presentation like this can do wonders for a child. When they understand their body and their environment, the human development, and what it takes to take care of the mind, body, and soul, then you reduce the chaos, or you learn to manage chaos and manage you. So you have power and control over your health. I'd like to thank Dr. Moros Salifu, Director of the Brooklyn Health Disparities Center, Dr. Marilyn Frazier, Director for the Brooklyn Health Disparities Center, Executive Committee at the center, and to our Sandra Chapman, who has constantly been a champion in Brooklyn Borough Hall, Lucchesi, and to all the staff and volunteers that just make the Disparity Center what it is today, for us to have a better sense of where Brooklyn is at. It's that gauging the needle, where are we, has to always be a constant reminder, a constant question we're asking ourselves. 2.6 million people in Brooklyn. 47% of all Brooklynites speak a language other than English in their household. That's a lot of global cultural competency. When you start thinking about the volume of languages, and does that represent what our medical professionals across all fields, you start understanding that the formula does not equate to a very good outcome if we can't communicate, and that's the first barrier. And then you add to that what is our cultural difference and trying to connect. How do you then develop the trust, the patient-doctor relationship, the patient-nurse relationship, the patient-psychotherapy relationship? I continuously, throughout the presentation, kept thinking of my dad. Recently, I had to take him to a cardiologist visit, and the cardiologist visit was very interesting because it's the first time I'm speaking to the cardiologist who last year had tested my dad for his carotid arteries, and there was a 30% blockage, and lo and behold, in less than a year, he had 100%. He's a diabetic. He has severe atherosclerosis. It was discovered that he was having a stroke in February because his 3 fingers were becoming numb in his right side. And the 3 fingers were misdiagnosed as neuropathy. A week later, my dad's arm completely failed. And that arm falling was the center of attention to now rushing to the emergency room. We're asking, when was his last stroke? He's never had a stroke. He's been having multiple strokes, very silent until they became symptomatic. How do you manage what are signs that are not there? How do you deal with teaching diabetics that the narrowing of your arteries is not just in your heart or on your neck, but that it's all over? My dad is slowly dying, and I don't have the heart to tell him, but he knows. One of the things that we're trying to manage is making sure that he's not demoralized. At this point, the doctor asked, when was the last MRA? How do you know that he has a severe atherosclerosis? I said, because we were in the hospital when he had the stroke. I had to explain to his cardiologist that he has 100% blockage, but also blockage all over. And what I'm interested in is understanding how to give him palliative care when the time comes. Not every patient would have a daughter asking those questions. Back. Coming together with the medical team for the patient. And always ask the question, who is the quarterback of that professional medical team? Because the doctor didn't have access to the MRA. My parents never thought to talk to the cardiologist about how there was an MRA. My parents that he would not know. He's the doctor. Why would we have to tell him? And so at this point, we're managing what is the caretaking of a 72-year-old man. 12 medications my mom has to manage. My fear is not my dad, my fear is my mom. While she's taking care of him, is she remembered to take care of herself? She's like a rock. She's older than him. And she's the one who's bathing him, who's caring for him, who's managing his medication. Recently, the pharmacy changed what would be the strips and gave it to her because the pharmacist felt that she needed to save money for the glucose strips. What occurred was that the strips, she didn't realize, were not fitting the machine they have, which we had ordered by a nurse practitioner who came to visit my dad. And it was a glucose reading in Spanish. That particular strip is specific to that glucose reader. And the pharmacist did not have notation of that. And she felt that my mom was just pushing what would be a brand name. This is not about branding. So I had to intervene once again. I am the quarterback. Making sure that the pharmacist understood when she said, your mother likes, and I understand, she wants the brand name. I said, don't judge my mother. She was asking you for that specific brand because that is the reader in Spanish that she needs the strip for. And it's not covered by insurance, and money will not be at this point. So do not try to save money at the cost of my father's health. He had not had his sugar level read, and sure enough, he had a 400, almost 500 reading level. These are the small examples of how the disruption of chaos can occur in fractions of a second. I could talk about my dad as your case study for a lifetime. But the Brooklyn Health Disparities Center is a partnership between SUNY Downstate Medical Center and the Arthur Ashe Institute for Urban Health and the Office of the Brooklyn Borough President. This is a unique community, academic, government partnership that promises to eliminate health disparities by bringing the assets of new and diverse partners to a strategic table focused on solutions. The health and well-being of our residents is a top priority and requires global competency. The overarching goal of the center is to eradicate health disparities plaguing minority communities in Brooklyn. The same communities for the last 50 years that have been plagued with the same issues. We must not be doing something right. And we have to figure out, what can we change? I talk about how genealogy is becoming more and more a necessary tool to understand who we are and how health and environment and diet and inherited illnesses are causing a fast-paced deterioration amongst certain demographics. Diabetes is being studied because it's a fast-growing illness. But I found out that there's a study for diabetes that doesn't include Latinos, even though we're the highest amongst all groups, because there's no funding for Latinos to be studied. And so how do you expect to address diabetes amongst the Latino demographic if we have no study funded for the Latino demographic? Inclusiveness in our health care studies is just as important as adhering to medical care. At Borough Hall, our agenda is to improve everyone's health and make greater strides in groups with the worst health outcomes. The Genome Center in Manhattan, the first in our city to be able to be dedicated. It costs $2,000 to get your DNA sequencing. Why are we not pushing for more of that to be happening here in Brooklyn? $2,000 stands in the way of us and greater knowledge. Us and greater knowledge, $2,000 per person. That's what it would cost. Where are the insurance companies here in this room, making sure that if they really wanted to reduce healthcare costs, they would have a study funded for this great volume of individuals in communities where the plaguing of obesity, cardiovascular, heart disease, you name it, we have it, right? And the zip codes are always the same. Where are the insurance companies trying to reduce those healthcare costs in these very zip codes by funding greater studies to understand the disparity and assist the Disparity Center? Keep in mind that all economic classes, racial groups, cultures, genders, and ages have a right to safe and healthy environments, but that is not always the case. Striving for equity, and while we do so, we live in chaos. New York City prides itself on being a global pacesetter in improving the health of its residents. Prescription management is an important component to optimize their lifestyle with chronic conditions. I spoke to my dad's cardiologist to reduce medication from 12, because my point was, why do we need to demoralize my father taking 12 medications when we know he is not operable? And so we are managing half the medications he's been taking for the last 9 months. He's a happy-go-lucky guy. He left that center with a cane, wobbling, the champion, because he got what he wanted. He was tired of taking 12 medications, and it was making him feel depressed. The medication alone, managing so much, so many pills, was enough to demoralize the man I know has a lot of pride, and that pride is what's keeping him alive. Enduring inequities in health have their roots in persistent inequalities in wealth, housing, education, healthcare, and employment. Still, with our work here and our continued advocacy, will ensure that Brooklyn is a place where all people can thrive in healthy neighborhoods. We all strive to continue making our Brooklyn a better place to live, and therefore this state. It is a great honor to be your Brooklyn deputy. And at this time, I'd like to ask the Brooklyn Health Disparities Center to please accept citations, proclamations, proclamations from Borough President Adams commending the work. As I read, whereas it is a time-honored Brooklyn tradition to recognize those individuals and organizations that demonstrate an outstanding commitment to community well-being by providing encouragement and offering. Much, Doctor. Thank you very much. And support to local residents and those in need, it is therefore fitting that we join in acknowledgement of their special events and occasions. And whereas all of Brooklyn joins today to recognize and honor the Brooklyn Health Disparities Center for the outstanding contribution it has made in our communities. And whereas on behalf of all Brooklynites, I salute the Brooklyn Health Disparities Center, a novel in 2004 between SUNY Downstate Medical Center, Arthur Ashe Institute for Urban Health, and the Office of the Brooklyn Borough President, that is committed to reducing health disparities in Brooklyn and increasing the level of engagement of academics, community members, and policymakers in the process. I applaud the Brooklyn Health Disparities Center for fostering community-engaged research that contributes to the elimination of racial, ethnic health disparities in our borough, and for the dissemination of information regarding evidence-based health findings among academic, community, and policy stakeholders. I commend the Brooklyn Health Disparities Center for its devotion to ensuring thrive and for having a positive impact on the lives of others. And I thank everyone for all that they have done to touch and improve the lives of many, helping to move our communities forward as one Brooklyn. Now, therefore, Eric L. Adams, President of the Brooklyn Borough, the citation on Brooklyn Health Disparities Center and all of you here today. Thank you, SUNY Downstate. And I want to end just by saying, I asked my dad after a long week of work, 12-hour days, 7 days straight for 2 weeks, how did you do it? You work 12 hours a day every day as a livery driver. And I don't understand how you managed. He said he was lying down on the bed with a right side paralysis. It was enough for me to understand I cannot live that life the same way because my health risks are higher, knowing what he has gone through. Take care of yourselves, Brooklyn. Thank you.
Thank you so much, Diana, for those wonderful remarks. We're going to continue on in our program. I mentioned to you guys that you do not have to go all the way to California, to the Golden State, to see a super team. The super team is assembled right here in this room. You first heard from Dr. Lewis, who talked about the inherent challenges and barriers in unpacking adherence. Then heard from Dr. Booten Foster. We can apply different psychosocial theories when we're talking about adherence. Now, the third member of the super team comes from the School of Public Health. She's a professor of community health sciences at SUNY Downstate School of Public Health. Please join me in welcoming Dr. Tracy Wilson.
Hello. Can you hear me now? I'll speak louder. Can you hear me now? All right. I'm going to talk today about patients living with HIV. Like many of us in the room, I prefer to talk about people living with a disease than being called, I am a diabetic, I am HIV infected. This way the disease becomes one component of something we're dealing with, but doesn't define the person. So just as Dr. Salifo spoke about the shift from the words compliance to adherence, I would love for us to sort of share the language of not using diseases to sort of define who people are. Not too long ago, someone asked me why I was still working in HIV. HIV is over, someone said to me. It is a chronic infection. There's not going to be that many more questions to ask and to answer. This is an astonishing thought to me because it's only true for a specific subset of the population. HIV into perspective for us, I think many of us are aware of these statistics, but we have about 1.2 million people living with HIV in the United States and about 47,000 new infections each year. 80% of those are among men and male youth. 44% are among Black people who identify as Black or African Americans, although people who identify in that group make up about 13% of the population. Injection drug use, which used to be a primary mode of transmission, has fallen dramatically in the United States, and sexual transmission is the primary route of infection these days. Living in a certain part of the country does not cause you to get HIV. But if you live in certain areas of the United States, your lifetime risk is very different. 1 in 13 people, your lifetime risk of acquiring HIV is 1 in 13 if you live in Washington, D.C., versus 1 in 578 if you live in Montana. So we're talking about racial ethnic disparities, but the disparities go straight down the line. This represents some of the geographic disparities. And here's where things get even more depressing. If you look at race, ethnicity, and gender, if you are a male who identifies as African American to the CDC, who counts these kind of statistics, your lifetime risk of acquiring HIV is 1 in 20. If you are a male who identifies as white or Caucasian, in contrast, your lifetime risk is 1 in 132. And when you start to look even a little deeper, these disparities, when you start to intersect them, become even more alarming. If you identify as African American, if you are a male, a man who has sex with other men, your lifetime risk of HIV diagnosis is 1 in 2. You are more likely to die of HIV based on what racial ethnic group you fall in. This is not a biological cause. Function of how our society is structured. So to look at this somewhat complicated graph, you can see that up until about 1996, 97, we did not have treatments for HIV infection. But around 1997, highly active antiretroviral therapies for HIV began to be widespread in the United States. And what you can see is that the death rate decreased very rapidly after that, but it declined much less rapidly in certain racial ethnic subgroups. So again, HIV is preventable, it is controllable. If you are diagnosed early in the course of infection and go on therapy early, you could live almost a normal lifespan. You could live for many years with HIV. but it depends on who you are, where you're born, where you live, which determines how likely that is. The focus of today is on adherence, but I wanted to note that we talk about HIV in terms of a care continuum with separate steps in order to get to the end goal of what we call viral suppression. These are talked about as behavioral steps. You need to be, but they're societally structured, right? So you have to be diagnosed with HIV early. You need to be linked to care and stay in care. You need to have someone prescribe therapy for you. And in terms of antiretroviral adherence, you need to maintain incredibly high levels of adherence to your medication through your entire lifespan. It's that adherence that gets you to viral control or are having HIV detectable in the blood. If we were able to get people diagnosed early and into treatment and adherent with medications, 3, we'll call them behavioral steps, we believe that we could avert 90% of all new infections. So if we could get people to be tested, we could get them linked to care, and we could get them to be adherent to medications, we would have far fewer new infections. And some people have talked about the eradication of HIV in the United States through expansion of these behaviors. Yet only 30% of people that we believe are living with HIV have their virus controlled. Only a third of people in our well-resourced country have their virus under control. We've done a much better job at getting people in to be tested. Dr. Sweeney's here, who spearheaded the Brooklyn Nose, the Bronx Nose, and now New York Nose, and rates of HIV testing, which used to be much lower in more under-resourced neighborhoods, look phenomenal. So thank you for that. So that 86% is a great number. It's gone up quite a bit. Yet only for about 40% of people living with HIV are engaged in care. Only 37% take their medications as prescribed. And it's that 37% that gets us to that viral suppression. Adherence is the key to getting your disease under control. You have to get on it. You have to take it over time. There are, probably not surprisingly, disparities in adherence. It's documented that persons who identify as African American or Black, we'll talk about why in a moment, are less likely to adhere. Somewhat surprising to me is an emerging body of literature that suggests that women are less likely to adhere to their therapy versus men. Huh? We can talk about why, maybe during the conversation. There's some discussion about the caregiving burden of women and how we tend to put everybody else first before our own health, but these are just sort of emerging studies. Okay, so the big picture in eliminating disparities in adherence are the things that, frankly, as a society, we should be taking care of. We need housing stability. I don't know if anyone is here from Housing Works, but we know that providing a stable roof takes care of most problems, right? So providing housing stability, food security, employment, these are things that help people get organized and get their virus under control. We also talk about in HIV syndemics of social causes of behaviors, lower adherence. This idea of syndemics are these overlapping social epidemics that are hard to tease apart. We talk about gender-based violence and sexual trauma among young men who have sex with men, among women, how that intersects with substance use and depression, how the epidemic of incarceration, people's stability, families, society's stability, how the instability of care when families and communities have large number of people cycling in and out of the criminal justice system, we don't have continuity of care. But of course, the issue of incarceration, housing, and food is much bigger than HIV. We have people living longer with HIV, and I don't know if we're going to talk about it today, but comorbidities has started to become a big issue. So comorbidity used to not be an issue in HIV. We weren't that concerned about whether you were adhering to your hypertension medication, but now that people are living longer, how do you begin to manage these complicated regimens and often the fragmented care when you have to go to one person to see your HIV care primary doctor, another person to manage your hypertension, maybe another person to manage diabetes, add to that substance use treatment, mental health treatment, and it becomes a lot to handle. If we could deal with these social environmental factors, we'd all be healthy across the spectrum of a lot of different diseases. Known individual level factors for adherence are a lot of what Dr. Boutin Foster talked about. Provider trust is huge, and it's linked with this idea of conspiracy beliefs in HIV. It's a term I can't stand, but people recognize it. And the idea is that the historical injustices that have happened in the medical system to underrepresented and under-resourced populations lives on. You'll hear people talk about, and I know we have some of our staff from our HIV Disparities Barbershop project here, who hear in the community regularly that AIDS was invented to kill minorities, that HIV medications are poisons designed to control populations. And I've heard people kind of chuckle about these beliefs, and yet there have been so many abuses. It's totally understandable that these beliefs would exist and would drive self-care behaviors. When we talk about discrimination and bias, we have to account for the fact that HIV is not just something that you manage. It's still a highly stigmatized disease. Overlapping stigmas in this case. We can think about sexism and racism, and now ageism, HIV stigma and sexual minority status. You can think of populations who have many of these isms sort of going on, and research shows that these are not just additive. Biological effect of being discriminated against on factor A, B, and C. It's not additive, it is multiplicative. And so the more you belong to subgroups that society discriminates against, the more it impacts your own health and well-being. We talk about internalized stigma, how society's discriminations and bias get under our skins, and to define ourselves by the way society, reflecting society's views. And in fact, these social environmental factors, yes, there's access to care, yes, there's a number of things that we can fix, but when you look at these factors all together, the weight of them, Carla, the term that you used was, when your slide on depression and demoralization. I think we're talking very much about the same things here, is that when the weight of all of these factors get under your skin, you are disempowered, or you can become disempowered as a patient. So what I want to talk about is this notion of empowerment. It applies in HIV. Most of the work has been done in diabetes and hypertension, and just now we're starting to think about how it might affect behaviors in persons living with HIV. The idea of patient empowerment is that people will act. I know a lot of healthcare providers are using the term patient activation now, right? It's the idea that people do what you want them to do, so they will take their meds and they will come into care. Patient empowerment is viewed as one of the stronger predictors of patient activation. The idea of patient empowerment is that if you can get patients to feel engaged and active in their care, if you can encourage a preference to have more information versus less about health treatment and options, if you can encourage a collaborative view on self-care and disease management, that's better. If you can build a commitment to maintain or improve one's own health, and if you can manage the uncertainties that are just inherent in healthcare, if you can help patients deal with the fact that I can't tell you that this will cure you, I can't tell you that you'll feel different in 3 days. If we can build interventions to help patients stay engaged, informed, collaborative, committed, and tolerant of uncertainty, they will be empowered to act, to maintain and build their own health. Chronic diseases, again, mostly in depression, mostly in hypertension and diabetes. The research shows that less empowered patients have less agency, right? Less feeling that they can control their own lives and their own health care. And so what you see is that people who report lower empowerment, lower partnerships with their clinicians, they miss more office visits, they take their medications less consistently, they ask fewer questions of their healthcare provider. I know there's a lot of providers here, and so you've probably sat with your patients who may not have asked questions when you would think that they might have a lot of them. This is a behavior that we think is indicative of lower empowerment. They have lower knowledge or understanding of their medications, and they report less confidence in their ability to manage their illness. This is a lot of the constructs that Dr. Boutin Foster was talking about. Empowerment hadn't really been talked about in HIV that much, so we've started to do a little work to see whether empowerment might be something that we should be focusing on in HIV. I didn't want to present too much data, but I'm going to talk for a moment just about a little study that we've been doing to try to get a sense of how patient empowerment may influence women's health. And I'm going to refer to another Brooklyn-based study here, the Women's Interagency HIV Study, which is led locally at the Brooklyn site by Dr. Deb Gustafson and Howard Minkoff. The Women's Interagency HIV Study has a terrible acronym. We pronounce that WISE. Whatever, it was before my time. Why couldn't it be the Women's Interagency Study on HIV? Then it could be WISH, but you know, whatever. It's WISE now, it forever will be. It's the largest national study of women living with HIV. It's been around for over 20 years. And for over 20 years, the nature of the cohort changes over time, come in at 6-month intervals throughout the United States. They answer very personal questions. They have a gynecologic exam. They have their blood drawn. They participate in our focus groups. They are an amazing group of empowered women who are dedicated to the idea of supporting other women living with HIV. The study, for those of you interested in these kind of things, we have about 3,000 women. Seroprevalent means that they're living with HIV, and a little over 1,000 women now who are matched demographically to the women with HIV infection. Since the study started long before antiretroviral therapy really hit, you can see that we have a large number of deaths. The deaths have shifted over time, so now women are less likely to die of AIDS than they were earlier. Now we're seeing deaths due to diabetes, homicide, substance use, cardiovascular disease, and things like that. In the WISE, about 77% of women self-report that they're adherent. I think we have someone who's going to talk later about measurement of self-report, but let's just say that's probably an overestimate of adherence. But it maps on with the proportion of women who have suppressed viral load. About 80% of women in the cohort, their HIV is not detectable. But even in a long-term study like this, where women are ostensibly connected to care because they're involved at academic medical centers, there are still disparities, which is somewhat remarkable and a little shameful, I have to be honest. Women who identify as white and non-Hispanic are significantly more likely to adhere in the WISE than other racial ethnic groups. But the thing that I wanted to point out here is that in the WISE, even after we control for the big things that we know are driving adherence in our populations, substance use, problem drinking, depression, lack of access and transportation to care, social support, as we heard earlier, even after controlling for that, this idea of patient empowerment is driving viral control. So the women who report higher healthcare empowerment on this 26-point scale, so there's a lot of points on this scale, for every 1 point increase health empowerment, there's a 4% increase in the likelihood of suppressed viral load. So this is kind of interesting. It's not saying that we don't continue to focus on the social determinants of health. We absolutely do. We absolutely keep doing what we're doing, but maybe in the meantime, there are interventions that we can be doing to promote healthcare empowerment. And perhaps this view where patients can't be empowered if they're active substance users or dealing with mental health or trauma isn't necessarily the viewpoint that we should have, even though traditionally that has an HIV been the viewpoint. So how do we build empowerment? That's what I want to talk to you about. The answer is nobody knows. We have a lot of research suggesting that empowerment is causally linked to better outcomes in lots of different disease models. And all of us have been signing our forms to get access to our patient portals, or been getting our patients to sign to get access to our patient portals, our electronic medical records and things like that, right? Who hasn't been involved in that? We've all done it. The move in patient empowerment today is to promote access to health records and utilization of that information. The idea is that this access gives people more information about their condition that they can act on. I have to tell you that the literature suggests that this is not going to be enough, although I think it's a good start. Has anyone tried to access their records and found it difficult or confusing? Right, me too. Me too, and I should be able to, use this information. I've given up many times with a number of doctors even trying. So it's not just promoting access to health records, it's improving health literacy and health numeracy. And better yet, it's on us to not require high literacy and high health numeracy for patients to understand their own health. So we need to think about how we can convey information very clearly, make it very accessible to allow patients to be partners in decision-making for health. There's a big move to e-health, electronic and mobile health technologies and skills to use them, so accessing health education programs on our phones. This is great too. We have to think, though, about computer literacy. We have to think about who has access to desktops or laptops or phones on a regular basis and what that means for our more disenfranchised patients. Trust in healthcare and healthcare providers is obviously a two-way street. It's pretty easy to feel offended if you believe that you're going to be offended, if your past experience suggests that you're going to be treated rudely because of who you are or what you have. So building trust in healthcare and healthcare providers is something we all need to learn. It's not something we can necessarily tell patients to do. So there's a lot of interesting interventions to try to build patient-provider trust, a huge barrier to healthcare, as was mentioned by our previous speakers, and to improve patient-provider communication. We do this through communication skills building, both at the healthcare level and at the patient level, to empower patients to ask questions and to demand that the answers make sense. Demand that the answers are then written down in a way that could be understood. And of course, consideration and integration of cultural features into healthcare. This idea of patient empowerment is really building, but we have very few interventions that effectively build patient empowerment. And so what I was hoping for today is a little bit of a dialogue about how we might do this, how maybe people have implemented improved patient empowerment initiatives into their healthcare settings, or ideas that we have, how we might collaborate to build this idea of control and a desire to control one's own health. I'm leaving it brief because I was hoping we could talk.
My name is Kim Thompson. I'm from the Rogerson Institute. My question in terms of empowerment, and commend all the speakers, you've done a fantastic job. I know for some people there may be a conflict of interest regarding the spiritual side of where a lot of patients may put a lot of, faith and trust in whatever spiritual connection they may have. I think there's something to an empowerment regarding trying to find a way to connect both those, both the medical side as well as the spiritual side to empower patients. I don't know if you know.
That quite a bit. I agree with you. And if you look in the social and behavioral science literature in HIV, there is a big black hole of scholarship. I believe that is because it is a bias of the investigators who do this research, who may not, I'm editorializing, by the way, but there's so much research on other areas of things that we know can help people with their well-being, and really only one or two HIV researchers looking at spirituality and religiosity in healthcare. We have so much more to do. The studies that have been done, you're absolutely correct. Spirituality and religiosity have been found to promote healthcare behaviors. In other instances, there's been fatalism reported, which is, it is God's will. I can't do much to change what's going on. We don't nearly know enough about how spirituality plays a role in patient empowerment, and how we can build upon and leverage some of those beliefs to sort of help patients with their quality of life, with their self-care management. There's really not much out there at that point.
So I'm an infectious disease doctor, and what we do at our institution is we have like a very strong peer support, and that really so. We know that, as we can see from what you just touched base on, as far as the MSM population, which is working with HIV. And so what we do at our clinic is when you get a confirmed tests, we try to, that first day with our preliminary positive result, we link you to, we have a very strong peer support team. And we'll try to link you according to that intake assessment with a peer. And that really, really seems to give us that patient empowerment that we're trying to get, because that peer, as a doctor and as healthcare provider, we can identify. I mean, we know, we're giving you this result, and with all the stigma that still lies behind it, and you're thinking, well, maybe I'm just gonna die, or I can't go home and tell my partner. So that peer is able to connect with you, and maybe questions that you might not share with your provider, and that seems to, get you to come back and keep that appointment. So I think that's also something that can strengthen that patient empowerment, because patients sometimes, there's certain things they'll tell provider, and when the peer comes back and say, oh, Dr. Dowie, the patient said this, I'm just puzzled because when we were talking, I didn't hear that. So that really, that's another, maybe collaboration and getting that seems to work somehow. And I know probably Dr. Sweeney probably can talk a bit on that with HIV, because we have worked with her at Harlem Hospital, and that peer group pretty much.
Yeah, thank you for that comment. And I left that out. Peer support, patient navigation, peer or near peer, someone who can understand you, who can help you with appointments and provide social support, can translate information, is a very powerful intervention. And it's been shown over and over to sort of help build the capacity of patients to come into care, to stay into care, and to adhere. I don't know if you'd like to add anything to that.
Thank you. In my capacity, city as Assistant Commissioner of HIV Prevention and Control, we had started a program with Ryan White dollars so that every person who was diagnosed in the city of New York in specific hospitals that wanted to do it, or not only hospitals, but places that did testing, we had started a program of education for newly diagnosed, run by peers. There were professional staff to help, but it was peer run. And there were 2 sessions. The first one was introductory. You've just been diagnosed, what does it mean? And then they had a morning with food. Anytime you serve food, you get better attendance. And so there was the first program, and then another day-long program, discussion about medications and what they meant in taking them and the challenges. So I don't know if it's still going on, but someone could check at the Department of Health so that everybody who's diagnosed knows that there's somebody there that they can talk to. Better at the source where they've come to be tested, because they already have a relationship, which is why we didn't make it at the Department of Health.
Yeah, thank you for that. I'll also add that's what's really interesting, sort of sidebar, is that the experience of being a peer or a peer navigator is transformative. And so we see flourishing happening in patients who serve as peers and patient navigators. It benefits everyone.
There's been discussion about, Downstate has patients from many, many different cultural groups. And I feel that we all have resources coming from our different cultures about how we handle illness and diet and things that aren't necessarily known to the mainstream culture and mainstream scientific culture. And there's sort of informal borrowing. You can see, for example, I can buy vegetables here that are part of my culture, and you see other people borrowing those and vice versa. But how can we sort of foster this kind of exchange, which I think actually has a lot of resources in it?
Thank you. That's such an important comment. For those of us who are committed to and community engaged, participatory research and application, the idea that a deficit model of communities is not what we look at. And so the idea is not to come into a setting thinking that you've got to create something, but to capitalize on strengths and resources there and to together, and so that people can know about them and we're not just replicating things. So greater movement toward understanding what these resources are and bringing them together is something we certainly talk about in the Disparities Center, but there's absolutely more room for that. I don't know if you have any thoughts about do that. There are things like asset maps that various faculty in the School of Public Health have worked on, where we're trying to understand sort of what's out there, and the Department of Health works on, but maybe the application of it isn't quite where we need to be.
Speaking of asset mapping, but also just sort of informal or semi-formal meetings and events or something like that to start with.
Yeah, it's a great idea.
Just one comment. One thing that we do as community health workers is we talk to them about the importance of making their time useful. So a lot of times studies do say that the patient has 5 minutes or less in the doctor's office. So we talk to them about the importance of making a list of questions and what are the 2 top or 3 top questions that you want answers for. And once that doctor gives you the answer, repeating that answer back just to get that clarification. That's one of the things that we do with them.
That is so excellent to have the community health worker model working on that building of communication skills, and that prioritization is just an excellent use of that relationship.
Thank you, Tracy.
Sure.
You've talked about the patient empowerment. Could you also comment on community empowerment? In other words, we want the community to actually take something that they actually appreciate, they buy into, they get engaged, and then we want to empower them to make the change. Can you discuss a little bit?
I would be happy to. So the concept of patient empowerment is borrowed from early theories of educational empowerment and political empowerment, which then was adopted by Barbara Israel and other colleagues who began to build models of community empowerment in Flint, Michigan, and in other areas. So there's a rich history starting in Michigan and other places in the United States through the last 30 or 40 years of borrowing from this idea of educational empowerment, political awakening, and building communities' capacity to identify and solve their own problems. It moves our role as public health professionals, one of supporting and supplementing with a few skill sets. So we can help. The idea with community empowerment is that public health can help provide maybe some resources or some infrastructure to do that. Maybe somebody like Dr. Joseph can pull the epidemiology together, but then you're having a community discussion about how you're going to prioritize social issues and what are the assets and resources available currently to solve those problems, and how can we come together to solve them. It is the essence of community-based participatory and participatory action research, which patient empowerment has completely just borrowed from. I think it's a good advance. Clinical research.
Comments or questions? Okay, I want to get credit for my steps today. Are all my doctors in the house?
Do you have your Fitbit on?
Okay.
Thank you.
A little bit of housekeeping. We are, of course, running a little over time. I would like everybody to feel free now to take a short break. I'll be coming out to ring bells, and then we will come back and we will continue with the program.
Register. Yes, we should. You can get.
Jessica.
Okay, everyone, we'd like to reconvene our wonderful conference. Okay. My name is Anika Daniels Osaze, and I am the Director of Diversity, Education, and Research for the College of Medicine here at SUNY Downstate Medical Center. And I hope you're having a fabulous time. I expect all of you to be taking copious notes because we have a lot of fabulous information here. We have great speakers, and all of the people here are well equipped to give you the knowledge that you need to move forward in any area of healthcare that you are currently serving in. So I have the pleasure of moving into the next segment of the conference and introducing our speaker who will be discussing interventions. Here we have Dr. Daniel Suker, who is the Associate Professor for the Department of Psychiatry and Behavioral Science. So we'd like to get right into the presentation because we are running a little bit low on time. So Dr. Suker, I'd like to welcome you to the podium at this moment. Thank you.
Hello, everybody. How are you? My name is Daniel Suker, as you just heard. I am a clinical psychologist by training. I am also serving as the research scientist at the Health Disparities Center. The reason why I say I'm a clinical psychologist by training is because what we've been hearing all morning is kind of this really broad, big view, and that makes me nervous because I don't know how to fix any of those things. But as a clinical psychologist, I do like sitting one-on-one, talking to people, trying to figure out how to help this person in this room move forward. And that's a little bit of what I would like to share with you today, some of the work that we've been doing. I'm piloting a new style of slide presentation here. Hope it works. So today, the theme is adherence. And I would like to talk about adherence from a couple of different perspectives. First, I would like to talk about, well, what does it mean to be adherent? And we've heard a little bit about that already. Then I'll talk about why are people non-adherent, which we've also heard a little bit about. And then are there ways of getting people to become more adherent? And I'll share with you some of the data from the clinical trials that we've been doing here at Downstate. So back to our initial question of what does it mean to be adherent? And you know, when you sit with someone, I say this is a lot like the question of, you know, what does it mean? Is it the same thing as saying, are you a good person? What does it mean if you are a good person, right? Well, I do like 9 out of the 10 of the big commandments, but I cheat on my taxes. Like, you know, are you a good person? Are you a good patient? How do we know who is a good patient and who is not a good patient, right? Who is really doing what they need to do and whose definition, right? Who gets to define? If you ask people, are you taking all of the medication that you're supposed to be taking? They often will say yes. And you'll go through the list. You go, oh, well, I don't take that one, right? So then, well, who makes the list of the medications you're supposed to be taking? Thinking about, you know, be adherent. So another way of thinking about it, is it a measure of a general trait or is it a specific behavior or a dimensional, you know, like kind of very particular, do you take this pill in the morning? Does that make you an adherent patient? You know, it really depends. So how we define who is adherent is very different depending on the type of study that we're trying to do. So when I'm going to be presenting shortly some of the results of some of the work that we do, but again, we're not using a really broad definition of adherence. We're using a really narrow definition of adherence. So what we have to do is we have to operationalize it. For each study that we do, we kind of reduce it to, well, this is the key behavior that we think that is important for these types of patients. So this is the one that we're going to study. But you know, the amount of ask, the thing that we ask all of our patients to do is much broader than all of the things that we're able to measure. And even though it's a limitation, I actually think it's an important strategy, because if we're thinking about, you know, how to allocate resources. So, you know, what are the most important measures that we really want people to be improved on or to increase their adherence to? So it is, you know, part of the task of the researchers is figuring out, you know, what are the key measurements? How do we measure that? And then can we make changes on those measurements? So there are different domains of adherence, and we've kind of been hearing a little bit about this, you know, from the different speakers. This is just one organizational structure that I like. So, you know, there's medication adherence, which is taking the right dose of the medication at the right time. There's appointment adherence, going to the visit when you're supposed to go, getting the test done that you're supposed to get done. Then there's dietary compliance, and depending on the illness, there's different foods you're supposed to be eating, not eating, fluids you're supposed to be having, too much, too little, what you're supposed to be having. And there's treatment adherence. Are you actually doing the things that the doctor asks you to do? And then there's behavioral adherence, which is like exercise, you know, cutting back on smoking, stress management. So that's a lot, right? I mean, that's a lot of, so those are all different domains of adherence, and depending on what illness a patient might have or what particular goal we would like to work on, we could fall into one of these domains, many of these different domains. But in terms from a research perspective, we really need to think about, you know, is it the same? First question, you know, if you give somebody a medication and they take it well, does that mean that they're likely to also be compliant with the treatment that you've prescribed as well, or the diet that you've prescribed? Is there really such a thing as an adherent patient? Do they do all the things that we're asking them to do, or are people really pickers and choosers? Well, that I do, that I don't do, that I'm never going to do, that I'll think about doing. So how does that really work? I don't think we even know the answer to that, right? I mean, we don't know from a scientific perspective whether adherence really even travels as a kind of general characteristic trait of the patients that we're treating. Why are people not adherent? We've heard many different versions of answers to this question. I'll share with you my approach. Because we're people, right? Everybody is non-adherent. And if you start off with the assumption that I'm prescribing a drug or I'm telling you to do something, therefore you're going to do it, by definition, you will be disappointed, right? So in mental health, I come from a mental health background. We have I think we're well seasoned at the expectation that nobody's going to listen to what it is that we tell them. It's more shocking, I think, in the medical community when they say you should do this, that people don't go and do it. So I think if you have a different perspective as a clinician, you understand that, well, this is what I think you need to do, that you think that you need to do, and let's see if we can have a conversation about that and see if we can move forward. So to kind of back that up in a little bit of data, so this is a study that we did on 312 kidney transplant patients all across New York City and targeting different ethnic groups and different socioeconomic status. So we had a group from Brooklyn that identified themselves as African American. There was a group in the Bronx that identified themselves as Hispanic or Spanish speaking. And then there was a group in Manhattan that was predominantly Caucasian. And what was interesting is, I'm not showing that data here, but what was interesting is, yes, there were differences between the ethnic groups, but there were also, but that's kind of complicated because they were all from different places. But when we really looked at it, there were different, the primary driver of the differences was not really ethnicity, it was the belief in the medication. If you thought that this medication was important to you, then people took it. If you didn't think it was important to you, then you didn't take it. And that cut across all races and all socioeconomic status. Now, it happens to be that there's a higher prevalence of people in both the Hispanic group and in the African American group that had less belief in the medication. But to me, that's a very different question, right? So now I can begin to understand how we're going to develop an intervention. So this particular slide that you have in front of you, look at that. So what you see here is people that in the blue are the people that were very adherent, and the people that were in red are people that were not very adherent. And the point of this is that these are all the different questions that we ask them, don't take their medication. And if you look, people that are not adherent, were higher on all of them, right? It's not like there's one particular reason. There's all of the reasons kind of combined together why people don't take their medication. Another observation that I would make is that, even the people that are very, very adherent, this blue line, they all, these numbers are not dramatically different than each other. They all had problems, right? There were too many pills per day. There were too many medications at once. They did have, and on the other side, they do skip meds when they're low on money. They do miss meds when their daily routine went awry. All of those things were true for lots of people, more true for the people that ended up being non-adherent. But adherence is really a challenge. And I think one way of thinking about, like I mentioned, allocating resources is that it's challenging for everybody. But there's like a large majority of people that do pretty well. And they take their medication and they come to their appointments, they do the things that they need to do. And then there's a sizable minority of people that don't adherent as the rest of the group. And those are the people I think that really need to be paid more attention to and perhaps supported in their ability to take their medication, find out kind of what's going on with those people and what those reasons might be. Study that we're ongoing now, I just kind of put this together for this talk. This is looking at lupus patients. It's only 28 people, but what I thought was kind of astonishing when you look at the shape of this, it's the same questionnaire. When you look at the shape, I'll go back for a second. Like the same shape, different disease, different group of people, same shape, right? So to me, as a psychologist, it's not a disease problem, it's a people problem, right? These are the issues that human beings have. And if you have one set of medical challenges, doesn't mean that you would necessarily behave entirely differently if you had a different set of medical challenges. This is how human beings respond to different challenges. So then, are there ways of getting people to become more adherent? And what I would like to do is share with you two different studies that we have done here. And I hope the answer to that question is yes. So the first study is adherence promotion in kidney transplant recipients. So if someone has kidney failure, there's two types of treatment. Certainly the best type of treatment is to get a kidney transplant. It's healthier for the patient, but it does come with a challenge that they have to take medications, immunosuppressants. So they have to take medications so they don't reject this foreign kidney, and they have to be very good at taking the medication as prescribed. And in fact, there is a whole field, really, of medicine, transplant nephrology, which is Dr. Salafu does and how we initially met, which is devoted to figuring out the exact right dose for taking the medication. But it's all predicated on the fact that people are going to be taking the medication in the way that we have expected them to. These it's such a careful balance of what they're trying to achieve that sometimes even relatively small amounts of non-adherence can throw off months or even years of a relatively stable kidney. Clinical trial, I don't know, it's a small clinical trial. We randomized 33 people, 15 went into our intervention, 18 went into our control. I'll tell you a little bit more about what we did. So it was a 2-session intervention, right? We met with a group of patients twice. And what we did was, these are the different components of what we did. So we talked about education. So these particular transplant patients, they've gone through a lot of education. They really understood very well, in fact, better than I, why they needed to take these medications. They had heard all the things that the physician said, but we wanted to kind of give them an opportunity to say it and to really show that they've really owned that bit of information. And we talked about their individual barriers and what were the challenges that they had as a group. And sometimes there were common barriers, sometimes there were individual barriers, and then we kind of moved into this behavioral, motivational interviewing, which was really trying to get people to find the motivation to really change. And then, once they got that motivation, we started to put a plan into place, and we did some behavioral modification. And then, here's what we should do. This is your particular plan. Your issue is you don't take your medication when you're not feeling well. Okay, why is it? Oh, it's because it's really hard to get out of bed or to go there. Okay, so what happens if you had an extra dose in your nightstand? Oh, I never thought of that. Okay, kind of a really practical, pragmatic plan. We did that. We talked about, well, are there other more emotional reasons why perhaps you don't take your medication? And I think there's like this undercurrent to all the talks that we've been hearing today about the demoralization, about the depression. I see it going as both ways. Certainly when you're feeling poorly, wants to do anything, let alone do stuff that is going to help you, down the road. And also, when you are really feeling sick, it's really hard to kind of have your spirits up. I mean, it's like this vicious cycle that feeds each other. The more depressed you feel, the worse medically you feel, and the worse medically you feel, the more depressed you feel. So we try thinking about, how does your mood impact your ability to take your medication? And then we have this thing which I kind of added at the end called cultural tailoring, which it was really the entire time allowing people to talk about all the things that perhaps they wouldn't talk about with their physician, because the physician might think, it might take too long to explain why they do what they do. And what was nice about this is that we had a group of people, and they were not selected to be together, but they were just kind of the people that signed up at the same time. And often there was this kind of shared camaraderie among them. Oh, you do that, I do that too. Or oh, I've never tried that, maybe that's a good idea. And it helped it move forward. These folks in general were very adherent, so I didn't really talk about the different ways of measuring adherence, but this particular way, we used a pill count. So we actually called them and had them count their pills for us over the phone, which is challenging. I don't know if I would recommend that, but that's what we did. Certainly more accurate, though, than asking people if they take their medication. Because if you ask people if they take their medication, the answer is always yes. And do you take it 88% of the time or 92% of the time? Well, let's do the math. Over the last 2 weeks, I'm prescribed 12 pills a day. So how many pills would I have to have missed to do 88 versus 92? It's an impossible question that we ask people. Obviously, there's no accurate answer to that. So, each clinical trial or each study really has to think of a way of measuring adherence in a meaningful way. And the way that we chose with these over-the-phone pill counts, which ended up being a lot more work than we had bargained for. People, as it turns out, don't like to answer their phone when they have their pills in their hand and count out 120 pills for you when you call them randomly. So we spent a lot of time hounding people, but we got it done. So at baseline, our control group was 94% adherent, and our intervention group was 92% adherent. Just kind of a random difference, not different. And then at the end, which was 3 months later, the control group didn't get any intervention. They were still 94% adherent. Nothing much happened with them. That's not surprising. But this 92% adherent group went up to 98% adherent. And, it was an increase, and it was a significant increase from baseline to outcome, and it was significant between the groups. The amount of change was significant. So it was very encouraging, right? So it was only 2 sessions. It was not the evaluation was extremely labor intensive, but the actual intervention was not very labor intensive. It was not like, anyway, we just sat and spoke with them and encouraged them really with a kind of a guided plan for 2 sessions. And it had, this amount of impact in just 3 months. The second study is a study that we are doing here as part of the P20, which is the grant that the BHD has. And this was a study looking at, and this is a more ambitious project. We went out into the community and screened people about their risk for sleep apnea. And we wanted to see if we could get them to come to the physician to get a formal evaluation. So another way of thinking about it is we went out to the community, asked people if they had a problem that they'd never heard of, and then wanted them to follow up with a problem that they've never heard of, and now we've told them they have. So it was a challenge. So it was a community-based participatory research. I kind of took over this project when it was, but there had been years of effort that have already gone into that project, kind of developing the community-based partnerships, deciding that this was an important area of research, deciding how they were going to, the methodology, how they were going to do it, where they were going to reach out, what types of people, what were the kind of important factors. And then what was also challenging is that this was a true community screening, that we went really out into the community. So it was health fairs, food pantries, kind of everywhere that, I don't know, Marilyn would take us. So I wanted to thank Marilyn, Dr. Fraser, who ran the outreach and the screening for our study. So, 100 people in 3 years. And this is 0 of those people walked through our door. We went out and found 1,500 people. That's I think, really a tremendous accomplishment. And we found some interesting things. So 14% of the entire sample probably had obstructive sleep apnea. When I say probably, it's because we did a self-report questionnaire. The real way that you get diagnosed is by going to the physician, which is what we were trying to get them to do, which is very high. The estimate in the community is about 3 to 4% is what the general population is supposed to have. So 14%, either our screen was a little not conservative, which is possible, or it could be that there are really high rates of obstructive sleep apnea in our local community here. 71% of those people have never discussed those symptoms with a doctor. So sleep apnea sounds like a sleep problem, but it's really a cardiovascular disease, right? It's a very serious medical problem. Just doesn't present very seriously. So people think it's kind of like insomnia. It's like, I'll deal with it or I won't deal with it, which is part of why we're getting out there, is to really educate people about its risk. And the typical treatment, if you have obstructive sleep apnea, is to get something they call CPAP, which is a mask that helps you breathe at night and prevents the closing of your airways. So 92% of those people were not using CPAP. So there were some people, a small percent of the people that were out there that we found that were already using this. Just as an aside, 38% of the sample had insomnia, and in 92% were not doing any formal treatment. That's, again, much higher than what national averages would be. And it's kind of interesting. I think that, when you think about why people have insomnia, you might think of the Wall Street executive who is working so hard and they come back and they can't fall asleep. I think that there's other, paradigms of why our patients in particular from this community might have difficulties falling asleep, or really maybe thinking about it, not the time or the space to go to sleep in the way that would be healthy for them to sleep. But again, 92% of them were not involved in any formal treatment. So we had, of those 1,500 people, we randomized 340 of them, 170 of them got this phone intervention. So what we did was we basically called them and we explained to them, community, right? If you got the control intervention, we gave you a pamphlet. We said, it's really important that you go get this checked out. We're going to follow up with you. Go get it checked out. Here's some information. And the phone intervention, we called people and we talked to them about what are their barriers? Why are you not able to go? Is it that you don't really think it's important? Is it that you don't, what are the issues? And, we keep a list of what all the issues are that people bring up. So it's really hard to get to a physician, right? And, this isn't, it's not the age of concierge medicine. You can't say, I want to go to the doctor at 7 p.m., right? You call the physician and you say, hey, I need a sleep assessment. And they say, okay, come, January 27th at 4 o'clock. You say, I'm working that day. Okay, come February 7th, right? I mean, so then you lost a month. It just doesn't, our healthcare system doesn't provide care in a way that is as flexible, perhaps, as many of our patients really need it. And we removed the financial burden. So if you had insurance, we billed it through your insurance. But if you didn't have insurance, we would pay for the physician's assessment, as well as the sleep test that you assume the physician might require. And what we found was that Of the original group of people that we assigned to the intervention, 32% of them ended up going, with those phone calls, going to the physician, as opposed to in the other group, without any additional follow-up, only 4%. So that means, 7 people out of the 180 or so during the next 6 months to get their sleep checked out. So not getting a sleep study, we didn't even go that far, just going to the physician to talk about their sleep health. And then, we kind of had this, because it is a community-based participatory research program, about 40 of the phone numbers that we got in the community were not real phone numbers. So we paid them $10 for doing the screening. So people said, yeah, you can screen me, no problem. Here's my phone number, and give us a fake phone number. So if you exclude those people, right, because we never reached them, even if they didn't have the best of intentions. Perhaps had we reached them, we could have done something, but since we weren't able to reach them, if you exclude that, then about 48%, half the people that we ever spoke to on the phone, we were able to get to go to the doctor, which is not great, but it's certainly a lot better than 4%. So what I really wanted to emphasize is that, there are multiple challenges, for all of our patients and for ourselves in kind of getting people to become more adherent, to become empowered patients that really are knowledgeable about what it is. And if you think about, what we know about, so most of us have a pretty focused area of expertise that we've chosen and we've spent a long time developing and thinking about. And as a patient, you don't really choose your disease process based upon your area of interest, right? I mean, so you're being told this is what you have to have, this is what you have to study up, this is what you have to do. And, that might be really challenging for people. So, to me, I think there's a lot of big questions that will require big answers, but some of the smaller answers might come from really just improved communication, giving time for people to express what their reservations are about what it is, and then being creative and brainstorming with them about moving forward and offering them support in doing so. And I'm happy to take questions now, or we could take questions at the end. Yeah, and partly because the disease often comes on slowly, so it's just kind of the way they've been for a long time, so they don't see it as like, oh, everyone's getting excited about it. There's a really great video, to your point, on I think it's the National Sleep Association, has a video entitled "What It Takes to Get Your Man to Go to the Doctor." And it's a guy sleeping, and he is snoring so loudly that his little kids come padding into the room, and they're waking up their mom so that they can get him to be quiet. And the video is of the mom showing the guy the video and saying, look how bad your snoring is, you need to go to the doctor. And he says, right? I mean, it's him with his wife and his kids. And then she looks at the camera and says, I still can't get him to go to the doctor, right? I mean, there's just so much in transience. People don't really want to go. They don't really think of it as a problem, especially sleep apnea. You don't really often remember it in the morning that it was difficult. So I think that why people go get treatment for sleep apnea is because their bedmate or housemate says, okay, you have to go. It's just, so bad. It is certainly a challenge. One of the things also is that the CPAP machines, or at least the traditional CPAP machines, are like a face mask, and people don't like sleeping with that. This is something that you hear a lot about. I'd rather die than sleep with that on my face. which is, I've only heard people that have not tried it actually say that. The weird part is that for most people with sleep apnea, they feel fantastic if they sleep with a CPAP machine. They wake up and they haven't woke the next morning without having woken up 10 or 15 times or 100 times through the night. So they'll feel so much better. And there are also, I don't know if they're available through insurance, there are smaller sized masks that are now Bluetooth. So they don't really require as much of the wiring, and it's not as like medical feeling. They're trying to, it's got a fan in it. It's kind of got this like higher tech thing. So there are some people that are, they're working towards, some sort of technological solution for, they make the cords very short, the straps are very short so you don't accidentally strangle yourself at night. So sometimes people find it to be very uncomfortable and restricting. Usually most people who really have a problem feel much, much better that they're willing to tolerate, the kind of restriction.
Just about information, there is a group at NYU that does sleep studies, and they have a program where they'll give you an iPad with access to information, and you keep it for a month or longer, and it's been quite successful, and I know they're recruiting, so if you're interested.
They grew out of us. No comment. Okay. Anybody else? Comments?
Thank you very much, Dan. So the group that did not have the intervention really didn't go, most of them didn't go to the doctor. So what do we do with that group? How do we approach them?
How do we what?
How do we approach them? Because we know they potentially have a problem. What is the next step for those patients?
In terms of the study design, well, when we reached out to them and we found out they didn't go to the doctor, we began to do we offered them, would you like us to do the phone calls with you, not as part of the study, just as, but it's kind of strange because if you're asking people, would you like additional help becoming motivated to go to the doctor, not surprisingly, almost all of them said no. And then, so when we first met them, we gave them a list of providers in the area with their phone numbers. We really tried to, connect them, let's say, as passively, but as warmly as we could. And at this point, there isn't much more that people were really interested in doing. For the intervention people, we were, encouraging them, and it ends up being, I think, because of our encouragement, a lot of them end up coming to our facility. That wasn't necessary. They could really go anywhere. It's just, it's hard. I think a lot of this is if you have a new problem, you want a friendly face. We're talking about community health workers or community navigators. That really, I think, in some ways, that was some of the role of what this motivational enhancement kind of took on, which was that, hey, I know this guy, he's okay. You'll wait a little bit, but he'll see you. It'll be fine. Okay. And then, when they came, it was like a more familiar experience to them as opposed to like dealing with a new hospital system and a new set of, expectations or experiences that they weren't really prepared for. Thank you.
I think that sleep should be a part of what doctors ask about, and they do not always do so. So how many people in here have had their doctors ask about sleep? So I think we have one answer to some of the things, the implications of these studies.
Unrelated to this, I just did a study with the medical school students where we asked them what's their knowledge about sleep disorders, what's their attitude about sleep disorders, and then what's their personal practice around sleep hygiene. So, our student physicians really know a lot about stuff, and they really are very poor at doing things. So, there's this kind of like, complicitness, I think, that physician, or this, weird feeling that a lot of physicians feel because many physicians are working many hours and they are not, they are cutting their sleep down to its bare essentials. And there's, really good data. So, there's protections now for residents, which is kind of interesting because now the work demand has spread from residency both up and down. So medical school students now are absorbing more of this. There's no protections for medical school students, so they're working longer. But what's even more interesting, I think, is that junior faculty are now picking up the extra shifts instead of it being the residents who are doing it. And, they have no protection, federal or otherwise. So they, you have to figure out what the ramifications are going to be for these folks when there's this demand that they do this. And, we have pretty good data which says that, under 7 hours of sleep, you start to make poorer decisions. So if you're chronically getting, 5 hours of sleep, that's the person you want making life and death decisions for you. It's a challenge. Right. I mean, that's where we see it, is when they drive home after the shift. That's where the data is, right? Where there's so many, X many accidents for physicians returning from the overnight shift. You don't really get to see about, well, what was he doing right before he left? Oh, he was doing open heart surgery. Okay. So, you don't get to, they don't fall asleep while they're doing surgery. We know that. But, is it possible that they are somewhat compromised? I would say probably.
Okay, thank you.
Thank you so much, Dr. Suker, for engaging us in such a critical conversation. Now I have the pleasure of introducing one of the busiest women here at SUNY Downstate, Dr. Marilyn Frazier, who is not only the Chief Executive Officer of the Arthur Ashe Institute for Urban Health, she's also the Assistant Professor in the Department of Medicine here at Downstate and the Co-Director of the Brooklyn Health Disparities Center. And she will be engaging us in a talk on patient community engagement, keys to better adherence. Dr. Frazier.
Wow, thank you. So 5 hours of sleep is not good. So today what I wanted to talk to you a little bit about is adherence, but talking to you about it in terms of community engagement and some of the approaches that we have used. So I'll talk to you a little bit about the Arthur Ashe Institute for Urban Health, and I'll talk about some of the factors that impact adherence. And then we'll talk a little bit about partnerships as we look at solutions with partnerships, community engagement, CBPR, which you've heard a lot about, and then we'll just summarize some of the work. For those that don't know about the Institute, I hope everybody knows about the Institute. It's a nonprofit organization that was founded by Arthur Ashe just months before he passed away. And a lot of our work that we do centers around community health empowerment. We were located right here at SUNY Downstate Medical Center, and Arthur Ashe created it in response to concerns about healthcare delivery in America. So a lot of our work centers around health education, health promotion, meeting people where they are. So we would go into beauty salons, barbershops, and talk to people in various walks of life. And another aspect of our work is our Health Science Academy, because we believe that we need to start earlier in terms of educating people about health and educating them about health promotion, educating them about cultural competence, because they'll be the next generation of our health professionals. So patient adherence was already defined. I know Dr. Booth and Foster did a wonderful job in talking about adherence and talking about compliance to some degree. And we have moved from compliance because compliance puts more of the burden on the patient and more of the cost for the issues upon the patient. So adherence brings us a little closer. I think we still need to do more work where that term is concerned. But we'll be looking at adherence in terms of the degree to which person's behaviors corresponds to the agreed recommendations. These are some factors, and this was taken from the global research report that was done in 2011. And I don't know if you're able to see it, but major factors are patient-related factors that impact adherence. We also have healthcare systems and provider factors, therapy-related factors, cost. We know that that's a big factor, the condition and the disease, and socioeconomic. And when we're talking about patient-related factors, we're talking about inadequate knowledge, perceptions of risk. We talked about that earlier this morning because sometimes people may perceive a disease as not being that detrimental to their health, and therefore they will not adhere to medication or regimens, and even misunderstanding of treatment. So when Dr. Allen spoke about, Dr. Allen Lewis talked about just the communication that has to be two ways, right? And misunderstanding of the treatment instructions, and even thinking about the follow-up, and just forgetting to take your medication because of the chaos that may happen in your life. And when we look at healthcare systems, we're talking about reimbursements and inadequate reimbursements. We're talking about health insurance, poor medication distribution systems, and barrier to care by providers. training, poor patient and provider relationship, and the time that's spent in communication and the style in which communication happens. Therapy related talks about drug effectiveness, how medication is taken. Is it oral? Do I have to take an injection? How often I have to take that? How many times my treatment might have changed over the course of my illness, and keeping up with those things, the complexity that comes with duration of treatment, having a long treatment regimen. Cost-related co-payment, out-of-pocket costs that people may have to shelf out to have medication. The condition and the disease we're talking about, severity of symptoms. So sometimes if something doesn't seem as severe to us, we may not pay attention to it. And sometimes we may not think of we may perceive the risk as not being that great, not thinking that if we don't recognize a problem right now, later on, we may have more complications and it may be more detrimental. And then socioeconomic issues. We have talked about social determinants of health quite a bit this morning, and thinking about some of the demographics, income issues, employment issues, social support, and of course, culture matters, and culture and beliefs matter quite a bit. So what do we know? We know that information is largely in the domain of health professionals and institutions, and sometimes it's often hard to navigate those systems because things are not shared on both sides. So where the patient is concerned and where providers are concerned, things may not be shared. And the cultural communities need to weigh in terms of talking about the things that matter to them, and also educating institutions and educating providers about culture is important as we move forward. Thinking about who makes the decision, who are the people that we need to focus on, who are the decision makers in the family. A lot of times the woman in the family may be the one, the primary caregiver, and the one that's making the decision. Community elders, folks that may be in churches or faith-based organizations, and they may be the primary decision makers. When culture comes into place too, in terms of some cultures leaving the decision on to the provider and thinking that, you know, the provider is trained to know these things, and so whatever they say, I don't need to question that, I need to just follow. And so all these things are important when we're talking about communities and when we're talking about institutions as well. And so we know that faith plays a big part in it. And then we have to think about, when does faith conflict with medicine, or how should when should providers think about how do they intervene? And then is there a role for the religious leaders in terms of caregiving? Things that we have to consider: cultural competency, and this speaks more to educating providers regarding in relation to changing demographics, culture that matters. Health literacy, we speak more about the patient education here, and the social determinants of health that you keep on hearing and you've heard a lot, because it does play a role, and those include the housing, the food security, the education, employment, income, race, and all those things. And then the importance of our partnerships, having effective partnerships. We know the definition, I'm sure, of culture, and this is shared systems of values and beliefs, and it's shared patterns of behaviors, and those things, it really matters, and culture does count. So in order for us to have optimal patient-centered quality of care, we need to pay attention to the culture, and culture on both sides, right? Because just because someone may be of the same culture, they may not understand everything the same way. And with providers and patients, we need to pay attention to how culture matters in that. Influences a whole host of things. So culture influences our attitude, the expectations that we may have, our perceptions of various things, our priorities, our coping style, how we decide to cope with something, our values, and our health beliefs. I know, as Dr. Buden Foster talked about the various things within certain cultures, the herbs and the different bushes that you'll use. And I remember my grandmother could give you a bush for everything. So for a cold, there was a different one. If there's fire, there's a bush that you'll use, or a tea that you will use for something else. And those things still prevail today. And sometimes we don't ask people what are the different things that they are using, but they believe in it. I've gone out into communities a lot of times, and people may have high blood pressures when we take it, and they say, oh, I know what to do. I'm gonna go home and take some lemon and some salt, and it's gonna be down tomorrow. Yes, and they take Epsom salt and they take salt, and it will be down. And so there are a host of different things that we are just unpacking when we talk about culture. Influence the decisions about where you'll go for treatment, how you'll go and seek treatment. People from different countries come with different health systems and may have different orientations about the process of seeking and obtaining care. And we come from systems where care may be free compared to going through insurances and going through paying for a provider. So it's a different system, and people need to understand that on both sides, as providers and also as patients. And when we go to think about our solutions, we know that it needs a multi-pronged approach. We cannot focus just on the patient. We cannot just focus on the provider, the systems. We need to develop partnerships and effective partnerships. We need to foster relationships, and we need to inform policy so that changes can be made. And the reason I put our slide up over the Brooklyn Health Disparities Center, because I think that's a unique partnership, and that's where a lot of things start. We have a partnership that you have a community-based organization, you have an academic institution, you also have a government entity, which you know, that's strange in a sense because a lot of places do not have that. We usually talk about community academic partnerships a lot, but there are not a lot of community academic and government partnerships. And our CBOs, we have a group of 12 community-based organizations that advise a lot of the work and inform a lot of the work of the center. So that's important, and that's an important starting point as we address health disparities, but also as we address those different issues around adherence and so forth. You've heard about community-based participatory research today, and basically this is a great model of telling you about what that is in terms of the community being at the center of that model, in terms of the development of the research question from the beginning, going all the way to the implementation of that, interpreting the research findings and disseminating the results. So when we were applying for our grant, our center grant, we had our community-based organizations through a Delphi process identify key priority areas that we should be focused on. And through that process, we were able to develop a shared research and policy agenda, which guided our work. And so high on their priority list, high on the community's priority list, were HIV and AIDS and cardiovascular disease. So our projects that we came out with were Barbershop Talk with Brothers, which is an HIV focused project, and our sleep apnea project, which is Dr. Sukor mentioned that cardiovascular disease. And the benefits of CBPR is strengthens intervention design and implementation. It also, the knowledge gain benefits the community. It provides resources to the community. It also increases trust because the community is an active part of the process of developing something that's culturally tailored to them. And it enhances sustainability of programs because you have folks that are trained that will remain in those communities long after we have left those communities. And in fostering relationships, a lot of our work deals with community engagement and going out, as I mentioned, and meeting people where they are. So we have conducted work in barbershops, our barbershop-based programs, and we've developed curriculum for barbers to speak to their customers about various things. And the barbers are close to the customers' ears. And one of the things that when they're that close, they could talk a lot and you're in their hands, so to speak. And one of the things that barbers like us to talk about is the history of the barbershop, that years ago, the barbershop was a center for health in a sense. Surgery was done there. They had bloodletting that was done in the barbershops. It was a dentistry place that they went to. And barbers like to think that, okay, you know, we're giving back to the community. And so our history speaks to health and being a health center, and we can give back to that process, or we can engage our customers again to promote health. So we have done a lot of work in barbershops across Brooklyn, and we've also done work in salons because our stylists tell us that they're the ones that everything too, and I know it happens on the other side with barbers too, and the men that visit barbershops, but they feel as though they're the counselors and they're the ones that people may talk to, and they want to intervene with a message that will help them to promote wellness and also to weave beauty and health together so that they can improve health outcomes. And when we think about policy, I know we're in a time where we're looking at healthcare transformation and the delivery system reform incentive payment program, or DSRIP, and that's focused on cultural competency and health literacy. I'm not sure how well it will work, but the plan is promising. It establishes a community-based approach for reducing health literacy and linguistic barriers, and community engagement and training. And those things are important because we need to train the next generation of healthcare professionals, making sure that they are culturally competent. We need to also meet people where they are, raise awareness. One of the things that we have used in addition to just educating folks about an illness and treatment, we also empower people to talk to their doctors and in giving them questions that they can ask their doctors. And sometimes people are often apprehensive about asking a physician a question, depending on which culture you're from, but that helps them to open the door and to start some of those conversations. Like this chart is a comprehensive patient adherence framework, and it was taken from the New Frontier in Patient Care. And it talks about how we can address patient adherence and different points in which we need to address that. And in the upper right-hand corner, it talks more about understanding patient leakages and their root causes. What are the causes of adherence? And then collaborating across stakeholder groups. We have different stakeholders that we've mentioned today, and we need to collaborate, and we need to have those essential partnerships. We need to also maximize places where we can reach our patients and reach people to talk about health education and promotion and adherence. And then ensure that we are investing in the group that needs to be addressed, and then enrich the patient experience. What does mean for that patient? What does having good health care mean? Making sure that we're thinking about what the patient needs to sustain their experience at a doctor, and then creating a mechanism where we can have feedback and positive feedback, negative feedback, but there is a place that we can have those communications that will help and that will elevate patient adherence. And then we need to just consider adherence, as stated before, early on when we are designing drugs, when we're starting out talking about an illness, when people are learning about an illness, we need to include adherence as part of that. So this is what I really wanted to just talk to you about today and just leave you with that. This is a quote that I've become more and more to like as time went on, that I know I could never forgive myself if I elected to live without humane purpose, without trying to help the poor and unfortunate, without recognizing that perhaps the purest joy in life comes with trying to help others. So thank you.
Do we have any questions, comments? Okay, you guys are getting close to that lunch need.
Yeah, I know I'm between lunch and...
We have one last segment we'd like to do before lunch, with your permission. I'm going to invite Betty Jung, who is also on our executive committee, to come up, and she will bring with her some special people onto the stage with us, really exactly what it's like to be a patient and their story about how it's been for them. So.
I just want to say these are members of our Brooklyn Diabetes Club that Linda Go and I have coordinated and hold on a monthly basis for the past 15 years. And I just want to say this is one of the strategies in helping the patient becoming much more adherent to the medical regimen, and also empowering them with knowledge. We also run the Book and Kidney Club, which one of them actually also is a participant. And we also have monthly community health seminars on many different community health topics that is of concern to the community today affecting the medical condition. What I'm going to do is I wanted the audience to really have the experience of what it is like from the patient's perspective, a visualized experience of what it's like when they were first told that they actually have a medical condition by their physician and that they have to manage it. So up on stage to your left is Hyacinth Brathwaite. Raise your hand. Cynthia Clark, Ella Toney, and John Hagenberg. So I would like to ask this question, and they're going to share their personal experience. When you were first told that you have a medical condition, tell us your experience. How did you feel? Anyone can start.
Good afternoon. My name is Cynthia Clark. I'll just share briefly. For me, when I was diagnosed as being diabetic, actually, all along the way, my doctor kept saying to me that I was borderline. And I really didn't pay any attention, that much attention to the fact that he was telling me I was borderline. I was like, okay, no problem. This one particular day, the secretary called and she asked me, she said the doctor wanted to see me, and it was a Saturday. And I said, okay. And I woke up that morning and I really didn't feel that great. And I said, I'm not going. You know, I'm not going to go to the doctor, I'll cancel it. But my mind said, go. And when I went to see the doctor, when I went to the office, I noticed there wasn't anybody else in the office. I was the only one. And the doctor called me into the office and he told me to sit down and he said, I have something to tell you. And he said, I want you just to relax and I'm going to tell you what I need to tell you. When he told me I was diabetic, put it mildly, I freaked out. I really became very agitated. I started crying. I thought it was the end of the world. It was just very devastating. It was a very devastating thing to me. But the thing that was good for me was the fact that my doctor was very understanding. And I think that's one of the important things with people who are diagnosed with diabetes or that are diagnosed with any illness, that your doctor needs to be there and needs to understand. My doctor sat with me for at least a half an hour to almost an hour. And he just held my hand and he let me cry. He let me cry. And after I cried, he said to me, it's not the end of the world. We're going to get through this. And this is what we're going to do. And we went through a whole regimen. And I have to say, I'm a nurse, okay? And I've been a nurse for 37 years here at Downstate. And it doesn't make a difference whether you're a nurse, you work on any type of job or whatever. But when anyone tells you anything about an illness, you're just an ordinary person. All of that medical profession that you know, all that knowledge goes out the window. So it's very important when you do see your doctor that you have a communication with your doctor and that whatever goals you make with your doctor, that they're goals that are understandable for both of you. Not just goals that the doctor makes for you, but that the doctor understands that these goals are workable goals for you.
Mrs. Toney?
My name is Ella Toney. How I found out I had diabetes was, I worked in a hospital and the in-service instructors came in 1996. They were demonstrating the new testing machine to do the blood. So I said, okay, after they finished, their demonstration, I said, well, check my blood sugar. So then I just checked my blood. So I give them my finger, they stuck it, and there they saw, it was higher. So I saw an endocrinologist that same evening, and it was about 200 and something. So that's how I found out I was a diabetic. So I said many times, if you have the opportunity also to do testing anywhere, because I remember years ago, people might go to an affair and then they may have testing people out there, and they test their sugar for the first time and they found out that they have diabetes. So then after I found, but I did not, acknowledge. That was in 1994. I did not acknowledge I was a diabetic. I had diabetes, and I didn't really comply with anything at all until 2 years after, in 1990.
And what motivated you to actually act on it? What motivated you to actually act on taking care of the diabetes condition? What happened?
After they found out, then the doctor counseled me. He put me on tablets. I think I started off on glucophage, and I noticed it. I used to have edema with it. So I told him, I'm not going to take this medication because I'm having edema. And that's, swelling off the feet. Anyhow, he switched me to another type, which was glyceride. And I was like, so you go down. And I noticed glucophage now is the same metformin. They just changed the name now to metformin as opposed to glucophage. But I'm taking metformin now, and I'm doing much better.
John Hagenberg, would you like to share your experience from the day you were first told?
Yes, I would. I was first diagnosed in 2000. Doctor found a high level of sugar in my urine, so he did blood tests. When he called me back and told me I had diabetes, I was in complete shock. Couldn't believe it, because a lot of things started going through my mind. My mother died from complications from diabetes when she was just 59. So that's the first thing I thought about. Life had just been cut short because I had seen all the things that she had gone through, the operation, the complications, the heart disease. And I was looking ahead and seeing a lot of that for myself. So he put me on medication immediately. Metformin, Actos, and later on Januvia, and now Invokana. And the hardest part is that as time went on and the number of pills increased, I was put on medication for Zocor for cholesterol. I was put on Tricor because my triglycerides were a little high. And slowly over the years, the number of pills increased. And although I take them on a regular basis because I have a lot of interest in staying healthy, it is a bit of a chore. The side effects from some of the medicines, particularly metformin, are horrible. I found out very quickly on that if you don't eat, when you take metformin, you have awful stomach aches. But some of the other medicines, I didn't feel like there were any effects at all. I mean, I couldn't see exactly what they were doing, except that my A1C was under control. So I assumed that that they were working without without a lot of fanfare. And today it's still under control, and I'm happy about that because now that I'm in my 16th year or so of diabetes, I realized that this was about the same time in the course of my mother's disease, when she started having the most serious complications. And she ended up in heart surgery a year later, which resulted in her death. But so far, I've been fortunate enough to be spared all of that. And I continue to stay active, to eat right, try to eat less, try to do everything that I read about and see as helpful to treatment of the disease. Better, develop, you know, maybe, but I don't know when that will happen. But I keep watching research news. I keep looking on the internet, watching health shows on TV to see if there's anything new.
There's a lot of options available to learn about your medical condition. Mrs. Brathwaite, would you like to share your story from the day you were first given the news that you have a medical condition?
Well, my story was my grandmother as a diabetic when she was 46 years old. She was a midwife, and I used to help her as a kid to test her urine. In my country, that was how you tested your urine. And she was always like 3+ or 4+, but she never went to the doctor. So she was taking herbs, sorcy, that was her medication. And her food was like steamed fish or meat. But I never thought that I would be a diabetic, because how I started out, they found that I was anemic. And I was going through testing, and then they found out that I was like borderline. And they started to give me tablets that didn't work, but I was in a research at Rockefeller Center who introduced insulin. But after 2 months, I was thrown out because I was putting on too much weight because I was eating. When I get out from the search, they couldn't follow me up because I was putting on a lot of weight because I was hungry. I was eating. I didn't understand what it was, and still bottling and the insulin. So I was at St. Luke's Hospital where they was checking me out, and they couldn't find out. And they said I was a syndrome X. My body was refusing to use the medicine that I was taking. So we had a battle fighting, changing the medications. I was on half tablets and half injection. Then from fighting and the education is very, very important. And you have to have a team of doctors. You got to go to your kidney doctor, to your heart doctor, everybody. And right now, I'm on 5 injections, but small doses, and it's much good. Nutrition is very important, and the education, very, very important. You have to be your own advocate of looking after yourself. It's very, very hard work. I don't want to get the young doctors afraid because it's a lot of work, And I recommend, I applaud the doctors that is doing this work. It's very hard because every case is different.
Were there any time in your life that you went off on your regimen? And what did you do to get back on track?
Sometimes, but I get back very quick. Very quick. You'll be tempted, but it don't last too much. You have to know how to cheat, because you'll be cheated. If you eat a whole apple, you'll be cheated. It's only a half an apple, okay? So, oh, well, I wouldn't do that.
We realize that diabetes is not a disease where they actually have any vacation.
To eat a piece of chocolate, it's not very good. Low blood sugar, that takes a long time for that sugar to come up. So please, just take a little piece, and that would be.
How long did it take anybody for you to change your lifestyle? How did a change in your lifestyle is associated with your medical condition? How did it affect your life personally and your family? Anyway.
Me with the cooking. My husband didn't have diabetes, but I put him on that. I put him on my diet.
Mrs. Tony, how much did this having diabetes change your life?
It changed my life tremendously. Because when I went to the doctor, of course, you do your blood test. So, because I always take back home my results. Here, my fasting blood sugar is good because you're fasting all night. And then the A1C comes back like 8.6. I remember once it was even 8.6. And that same day I came to diabetic lecture here. And I remember saying that to Betty. She would call me about 10:30 the night and say, here are some endocrinologists, phone numbers. Please go and see someone, and give me phone. I did not follow through because I always just did not pay any attention at all to my diabetes. As I said, I didn't accept the fact that I had diabetes for 2 years. And then a year after, I noticed all along the A1C stayed high. And another thing that I didn't do was take my cholesterol medication. I would wake up on mornings, check my pulse, and the pulse rate is under 60. And not adherent to my. So therefore, one day I woke up with a chest pain. I went and saw my PCP. He sent me to the hospital. I said, no, I went to a wake yesterday. I went home and drank ginger and all that. The next day it got worse. And of course, I had to go straight to the emergency room. They ran tests. And they said, well, something, you have an MI. So therefore, we'll be running a cardiac catheterization tomorrow on you. Based on that, maybe a stent will have to be inserted. And that surely did occur. Since then, now I'm really not trying my best. Trying to follow the regime as I'm told. And recently, I've started going also to some diabetic lectures that talk about the carbohydrate, regime, because I continue to eat everything. If I go to the bakery and they have fudge, I'll buy it. If they have peanut sugar cakes, I'll eat it. My sister might send a fruit cake for my sister or brother, and I tasted it and it tasted fine. I wouldn't even share it. But since I'm doing this carbohydrate, I now start really truly understand diabetes. Now I became I found it out at age 55. I'm now 77. So I do my exercise, I go swimming, and I'm really now sticking to this carbohydrate diet.
Thank you. I just wanted to add, of all the types of community seminars and clubs that I do coordinate, this is a representative of gender percentage that I am seeing in all of my group meetings. If you ever come to any of my group meetings, no matter what, topic I hold, the majority of the audience is, guess what?
Women.
Women. So we need to get a male perspective. John, why is there such a small percentage that actually come to educational seminars?
I think the reason is basically the male attitude. Men seem to have a harder time accepting the fact that they are ill. They have the feeling that somehow, because they're men, they can tough their way through it, opposed to just, giving into the treatment regimen. And they just hope that maybe they can make the adjustment on their own, exercise. They have the male ego gets in the way. They're like, well, you know what? I can handle this. I'm a guy. I can handle this. So they're a little slower to come around and accept the fact that they have an illness, education, because they feel like they can do it on their own.
So it's something to look at. We do have to really pay attention to the men, but unfortunately, they are the ones that get diagnosed, many of them at a very late stage. So it is the men that we really, really do need to reach. And I'm so happy that Dr. White has a brothers program, barbershop, that really are reaching the men in the community. We can entertain questions, some questions, so we can go to lunch. So anyone has questions?
You took me off of my jogging activity. Okay, so some housekeeping. Obviously, we're running late, but we do have our assistant commissioner here. I'm going to suggest if he would allow us to go to lunch, and then he'll come back and talk. So why don't we break for lunch, and please come back. Let's give a hand to our technician. One more thing I just want to say, if anyone is leaving the conference, come back. I'm going to cut lunch a little bit shorter. Let's come back at 1:45, okay? And also, if you're leaving, please leave your name tag with Lakia at the registration desk.
Check, audio check, 1, 2.
They're coming. They're coming. They're coming. Yeah. Too much time. Okay, everyone, we're running pretty much behind, so I'd like to get started. We have some folks who are still outside. They'll join us as they join us. Okay, so how was lunch? Okay, good. I'm going to make a request. We gave out these lovely bags and we really appreciate them. But if while people are speaking, we can avoid moving the bags because they do come in on the sound. You know, beggars can't be choosy. We had the good fortune of being offered them, and so we took them, but they are some noisy little things. Okay, and so one of the things that you know is from this morning's presentations is that we work hard to make connections that we know will be of import to the communities we serve. Very fortunate because we've been able to connect with the Department of Health in New York, and we've supported their projects and they've supported ours. And in that regard, I'd like to introduce you to Dr. Torian K, middle initial K, Easterling. And he is, and I'm going to read this, no prompters, the Assistant Commissioner for the Department of Health and Mental Hygiene. But we like to call him our commissioner because he is designated to Brooklyn and he comes whenever we call. So Dr. Easterling.
Good afternoon, everyone. Such a pleasure to be here. I would just want to commend Dr. Salifou, Dr. Straker, the Brooklyn Health Disparities Center on yet another fine symposium and seminar on such a critical issue around adherence to medication and patient adherence. As was already mentioned, my name is Dr. Torian Easterling. I do serve as the Assistant Commissioner, but for Brooklyn, for the Department of Health. And the connection is quite clear because when we think about adherence to medication, patient adherence, when we think about who needs to be activated around this issue, is not just healthcare systems, not just physicians, not just healthcare providers, but we're also thinking about pharmacists, faith-based organizations, community-based organizations, barbershops, beauty salons. There are people in our community who have the ear of their residents, of their neighbors, and we all need to think about what is the alignment and how can we make those connectivities. And so for Commissioner Bassett, this is something that she's been really truly raising the alarm around how do we add sort of a health equity lens to all of our work. And so when I look around this room and I see their students, their healthcare providers, their leaders around health, and other social issues, we understand that this issue is not just a health-related issue, right? There are social and economic implications that we have to take into account. And as we heard from earlier, as some of our patients have raised, economic issues that physicians have to have conversations about, right? There are critical decisions that individuals are making about whether or not to purchase their medication, pay their rent, put on their lights, pay their child's school fees. There are things that we have to consider when we're talking to individuals within our community. And so one quick fact, and I chose not to do slides and chose not to do a whole presentation, but one of the things that we highlight, particularly in Brooklyn, so Brooklyn has the highest rate of premature mortality than all the 5 boroughs. And so when we think about the number of people who die before the age of 65, Brooklyn has the highest rate. We don't have to get into numbers, just understand that that is the fact and that is the truth. You can absolutely go onto our website and you can see those statistics. But if we underline the number of people who are dying before the age of 65, and then if we talk about, well, there could be health behaviors, there could be genetic related, but we understand that there are other social factors, and this is where we talk about health inequities that we have to consider. We talk about the root causes of health inequities. Yes, we can talk about health behaviors, but then in that same conversation, we have to layer it with gender discrimination, systemic racism, structural racism that exists within our institutions, right? And so we have to call out medical mistrust that we hear quite often from our patients, right? And the gentleman spoke about the resistance among men to even engage health providers. There is a reason, right? And we have to uncover and unpack that. And if we are not willing to be bold enough to have those conversations, then we're going to continue to have this symposium for decades on end, right? And so it's great that when I looked at the agenda and I saw that we weren't just talking about the issue from a medical perspective, that we were also engaging it from a social determinants of health. And so I'm happy to bring this quick and short message from the Department of Health, where we've just established a Center for Health Equity. We wanted to really amplify the health department's mission to address the root causes of inequities. And that includes structural racism, discrimination, and particularly naming racism by its term, right? And so there are things that we're doing. Yes, we're investing in key neighborhoods. So in Brooklyn, we work in Crown Heights and Bed-Stuy. We work in Brownsville and East New York, in Manhattan, Central and East Harlem, in the South Bronx. Many know Claremont, Bathgate, Morrisania. Because when we look at the epidemiology, we can see that in all of these neighborhoods, it's quite the same. Whether we look at voter turnout, 311 calls, we layer that on with asthma hospitalizations, we layer that on with poverty, with violence, the indicators are all the same in all of these neighborhoods. And so if we're only going to have a conversation about health behavior, then we are totally missing the boat. And so we have to have a full conversation, a comprehensive, about the social factors that really lead to the health outcomes that we're seeing in these neighborhoods. Happening here, again, I commend the leadership at the Brooklyn Health Disparities Center and all the different community partners who are here. And I'm going to take my seat and continue to listen to the speakers. So thank you very much.
Okay, I'm not going back up the stairs. Okay, thank you, Dr. Easterling. When we thought about putting this conference together, we wanted to be certain that we had representation from many disciplines. And so to that end, we are very, very fortunate to have Dr. Gerard here to speak about, and with my on, okay, to speak about enhancing adherence through practice, education, research, and policy, the role of nursing. Welcome.
Thank you so much. I'm delighted to be here. It's like coming back to my roots. When I was reflecting on putting this together, I thought this feels like when I was a student nurse and my very first day of nursing school, when they drew this picture on the bulletin board or on the blackboard. That's how old I am. We use chalkboards. Of course, we still do have some of those here at Downstate. We drew that picture on the board with the patient at the center, and then all of the care providers around that and the community surrounding the patient. So it really feels like I'm coming full circle. This topic of adherence, and I'll speak more to the terminology in just a minute, is definitely a nurse thing. When I was starting to put this together, I put in the Google search, the nurse's role and patient adherence, and I got 78,200,000 hits. So I said, well, this definitely is a nurse thing. So let me see what I can do to put some of those pieces together for you. And what I thought I would do, in keeping with the objectives of the day, is I'm really going to focus on the future. I'm going to talk about some trends that are going on in nursing and nursing education that you may or may not be familiar with, and talk a little bit about some thoughts about where nursing in particular can play a role in moving this forward. Let me see. Okay. I want to comment on the term adherence, and I was so delighted to see that I'm not the only person that struggles with that. I always had trouble with compliance. I never felt adherence was a great shift forward, and I sort of forced myself to, why did I react that way? And maybe it's because I'm such a non-adhering, non-compliant individual that that those words make me a little bit uncomfortable. But I feel uncomfortable in using that with patients and with communities, because it seems so critical. Because I'm so sensitive about that word used towards me, that I reflect on that about our patients. So we do need a better term, and I understand that Margaret Kaplan is going to help us with that. We heard this morning. But we do need a better term. We need something that really implies more of a partnership, I think. So that, with that caveat aside, I came up with this alternative, but it was late last night and I'm on a lot of cold medication. So it's not perfect, but it's really about achieving a goal. Adherence isn't a goal. It's what we're trying to achieve with our patients and our community's health. That's the goal. So I came up with this: successful implementation of a patient, family, and healthcare team developed plan of care, which obviously has too many words in it. But that's the essence of what I want to talk about. In nursing education, nursing practice, we really are and have been for several years on what we can do in terms of changing practice so that we can have achieve this goal with our patients and our communities. The key message from the IOM report on the future of nursing that has guided us in our transformations as a profession and as nurse educators is that nurses should practice to the full extent of their education and training. This sometimes comes as a surprise to our colleagues in other disciplines, not so much to nursing. And I'll show you some examples of how this is a real opportunity for us in nursing. I go back to the basic standards of nursing care and nursing practice, and I selected a few that seem to resonate with what today was all about. First, standard 4, planning is individualized and developed in partnership. That's one of the standards of nursing practice. The plan is implemented in partnership, but it includes care coordination, health teaching, and health promotion. Again, all themes that I've heard throughout the day. Standard 6 is progress toward attainment of outcomes is evaluated. And in this case, I just want to emphasize that it's evaluated not by the care provider or by NCQA or by the Joint Commission, but by the patient, the caregiver, the consumer, whatever we call the person that we're working with, in relation to whether or not it's working for them. And that's the most important thing. Standard 13, practice is done in collaboration and partnership with consumers, families, and other providers. And what that means is that it really does take a village, and it does take a team, as we've talked about throughout the day again. This gives you an example of a practice transformation. The Josiah Macy Foundation has just released a preliminary report and will be shortly releasing the full report that talks about this issue of engaging nurses more fully in their role and more fully in primary care. Primary care, as we have defined it, really takes place everywhere. When the patient's being prepared to take care of themselves at home, that's primary care. When the patient comes into the ED and is assessed as to whether or not they have had their pneumonia or their flu shot, that is primary care. So primary care is taking place in a whole variety of settings. Initiative is particularly focused on the role of the nurse in sort of those traditional primary care settings. And you can see when they talk about today, think about the role of many nurses in the primary care setting. It's one of individual assignments, triaging patients, taking vital signs, and so forth. What the initiative of the Macy Foundation is all about is marshaling those registered nurses through our educational programs and through practice to really make a difference and be a true member and practice to the extent of their license in the practice setting. So we're looking for nurses really practicing more fully and engaging more fully in primary care. And I'll talk a little bit more about some examples of that in a minute. This is an example of a primary practice innovation. It's a group practice setting, and this is the only one, but this is one I heard about recently. And they have core primary care teams. It's a group practice. There are, each team, it consists of 3 RNs, an MD, an advanced practice nurse, a nurse practitioner, who see a panel and are assigned a panel of patients. The RNs are probably the major player, spend the most time with the patient. Not the nurse practitioner, not the physician, but the RN. They see the patients on admission, health assessment of the patient, do their medication reconciliation, which is, as we've talked about today, such a big piece of care, evaluate the patient's progress towards meeting the goals, and so forth. Then what happens is the patient is seen by the nurse practitioner or the physician, depending upon what the needs of the patient are, who's part of that team. They see the patient usually briefly, but they see the patient with the RN, who is the patient's care coordinator, and with the patient, of course, and together they decide what's going to happen next. They have found, and they have studied this, that they are more productive as a practice, i.e. they see more patients, generate more revenue. They've lowered the costs of their care, both to the patient and across the practice, and they're getting better reimbursement. And they have greater patient and provider satisfaction, which they have measured. And as many of you may be aware, one of the things that's sort of drifting through our healthcare system today is the joyful practitioner, which I find is an interesting concept. But we know that productive and happy workers achieve better outcomes, whatever the setting is. And they're finding that in this clinic, they support one another. The team really works together and really works with the patient. So that's an example of a primary practice innovation where nurses are used to the full extent of their. This comes from the website. You'll probably recognize it. There's a lot of nurse-led initiatives here at University Hospital that, although they're not new, they certainly are bright spots. And we've heard about some of those today and saw some of the people who are being served in the community. But I think this is an important way of thinking about how we utilize nurses to provide health care. We also need to focus, obviously, on transforming education, a little slower probably than transforming practice, but in order to achieve the goals that we want to achieve with our patients and with our healthcare system. The key message from the IOM report on the future of nursing says that nurses have to achieve higher levels of education and training through improved educational systems and really change the way in which we provide healthcare. So we need to teach our nurses to not practice for yesterday, but to practice for today, and more importantly, even for tomorrow, using some of these new models of care that are evolving. And across the nursing community, there are some things that are relatively innovative. I know in medicine we've heard about some of the things that are going on to change medical education, but nursing is doing the same things. One of the things that has really made a difference in nursing education is QSEN, the Quality and Safety Education for Nurses, in which the core competencies, and if you're familiar with the core competencies for the health professions that were developed probably 20 years ago now, those were used as sort of foundational for QSEN. And the emphasis is really on patient-centered care and teamwork, which is really important to the kind of things that we're talking about in achieving outcomes and teamwork with our patients. The Foundation report has called upon nursing education to really look at integration of classroom and clinical teaching. Again, parallel in other disciplines, certainly in medicine, doing the same thing. Another thing, and this may not be familiar to everyone, but we do have a nurse residency program, and some of our nurse residents are here today. Residency programs have sprung up over the last 5 to 10 years all over the country in hospitals, in schools, and also in community health agencies to prepare nurses for different kinds of roles and to more actively engage in all aspects of their practice. And then a very new thing that's happening right here on our campus, which we found out 2 days ago. We received almost $500,000 for the College of Nursing to design a nursing education certificate that will help to prepare future faculty. Like with many disciplines, our curricula are so crowded that there are not a lot of courses in how do you teach other people to do what you do? How do you teach nurses to be nurses? This is an initiative that is also going on across the SUNY campuses, looking at how do we take people who are getting masters and PhDs and prepare them to teach our university settings. So we have a grant here, and so we just found out 2 days ago, and we're in the process of getting ready to gear up and work with our colleagues in medicine as well as we begin to move this forward. So that's happening right here on our campus. Policy obviously also has to be transformed, and that's educational policy as well as healthcare policy. The IOM report on the future of nursing, again, said nurses should be full partners with physicians and other health professionals to redesign healthcare in the United States. And it's really essential, and I know we do a good job here, in the fact that we need to have all of the stakeholders at the table. And that includes our patients, but it also includes all of the healthcare professionals who are engaged in this process. A real challenge, but something that's important to all of us. Some of the policy changes that are ongoing across the country, and I know have certainly touched us here in Brooklyn, and that is to engage nurses and other healthcare professionals in making a difference in the direction of policy. The Affordable Care Act has certainly increased the demand for services and calling for practice transformation across the country. We're pushing hard as well as a nursing community, but with our colleagues, to get statutes and regulations changed, especially for the advanced practice nurse, so that nurses can really practice to the extent of their preparation. Nurses also are getting engaged in value-driven payment. The structure should include care coordination and other activities that are so vital to our patients and their ability to get well and our ability to assist them in doing that and maintaining their health. And finally, institution and organizational policies really need to be developed to maximize nursing contributions. We all practice as we were taught. We all do the things that we learned, and we need to think out of the box a little bit more and say, how can we do this differently? Whether we're talking about educational policy or policy in the practice setting. Some current initiatives that are going on in relation to influencing policy, the Robert Wood Johnson Foundation and AARP have a coalition. It's called the Campaign for Action to really move nursing forward in the policy arena. There is a specific initiative to increase the number of nurses who are in the boardroom for organizations, for hospitals, for healthcare organizations, for community agencies. I know myself, I've served on several community agencies that or an appointed official, and people said to me, why would you want to do that? Like, why would you want to be on city council? And I said, because it's about people. And one of my first days as a city councilor, the first issue that came up was about the landfill, commonly called the dump. This was out in the country, it was in New Hampshire. And I got very concerned about the health issues associated with that, because the city engineer said, oh, there's no problem, because somebody was asking about the leachate from you probably, in the city, you don't know about this. Leachate from the landfill it was right on the Connecticut River, going into the river, and the engineer said, the city engineer said, it's not a problem, it goes downstream, it's not contaminating any of our wells. And I said, pardon me, but as a nurse, I really care about those people down the river. So to think about nurses getting involved in things and other healthcare providers that we don't think of traditionally as nursing care, but we've talked about those issues today and how vital they are, and that's a real difference in the way in which we look at health and healthcare. And finally, nurses in the policy arena. I love the ANA logo, when nurses vote, policy changes. I wish it were quite that simple, but certainly it does make a difference. Another area in